Yeah. So what the Ministry of Health comes up with as a policy, we play our part and come down to implement. I will stop there. I have the ability to go on and on. Asante.
Asante sana daktari. I like very much what she has said, that as regulators, we need to be open-minded. So I've taken that as, since she's a regulator, it means that she's open-minded. Sindio? So it means we can actually have the how shall I say, the true and honest conversations that will help us to move forward. So I hope you're collecting your questions and your comments. Me, I'm just collecting the buzzwords. We had the midwife. Then now we had the perineum. We are still going. I had the beautiful one. My middle name is Nyakeo. So I think you can see how we ended up there. So like I mentioned earlier, we are going to dovetail the sessions. So we have discussed, or we've had some initial remarks about the fact that we have deployed, POCUS. And the case for POCUS, we don't need to go back there because it's quite clear. And we've put it in the hands of, let's say, non-traditional cadres that are using it. And how do we want to now mainstream this? And we've had the people that are talking about, the usage and the regulation of it. I would like to invite my colleague, Dr. Goako, to just move us on to the next session. Before now, we have the whole panel talking about training and regulation. Asante.
Thank you, Charity, for coordinating the session wonderfully. My name is Dr. Waka. I think I'd introduce myself from the University of Nairobi. So we've had from the ministry, we've seen the numbers, we've seen the strategic plans. We've heard from the researchers, AMREF, Kenyatta University. We've heard from the regulators. So this next session, we are going to hear from academia and professional associations. We have quite a number of questions for them that we want them to answer. Number one, do we have a curriculum on ultrasound and specifically POCUS? Number two, we want to hear how do they adapt to reflect any changes in the scope of practice. Like we're talking about training midwives, training nurses, training clinic officers, training medical officers to do point-of-care ultrasound. How do they incorporate that into their curricula? Are there any innovations that they've already adopted into their curricula? Are they experiencing any challenges? And what would be their recommendations to us as stakeholders and to the ministry with regard to how POCUS can be utilized? To answer these and more questions, I have the pleasure of inviting three. We'll start with Professor Miriam Wagoro. Professor Wagoro is a trained midwife. She's a mental health nurse. She's a researcher, sits in several boards and associations. She sits in the Kennedy University of Nairobi, ERC. She is the immediate former director and I think chairman of the Nursing School, University of Nairobi. Karibu, Professor Wagoro.
Hello? You can hear me now? Thank you. I'm saying that I'll go very fast because we've been told time is not on our side. I thought I would present this for a longer time, but I have to shorten it. So I want to start with the introduction and role of academia. And we know that academia really plays an important role in shaping and defining the scope of practice. We know that regulators regulate the training but we define the scope of practice with the policy makers in nursing and the regulators in nursing. Because we know the kind of people we train. We cannot say that this person, the nurse that we are producing, will be able to conduct a delivery when we know we have not taught them how to conduct delivery, we have not taught them the reproductive anatomy and physiology, and so they really don't have any idea. And we have not also taught them the reproductive biochemistry. So academic institutions are also in the forefront of research. At the University of Nairobi, we say, you either publish or you perish. And it is not just publishing, it is publishing that impacts policy and practice. So we have said training is regulated by the NCK, but we have to know what kind of nurses do we need or midwives we need in this country, and that we do together with the policy. So policies are developed at the Ministry of Health. I hope we still have the Directorate of Nursing and Midwifery. When I used to work at the Ministry of Health, we had the Division of Nursing and Midwifery. So we standardize qualifications. We define the minimum qualifications needed to practice. If I'm training a Bachelor of Science in Nursing, and the Bachelor of Science in Nursing we train in Kenya has 3 skills. They are midwives, they are general nurses, and they are community health nurses. So if I'm training that kind of a nurse, I should be able to know at what level should they get into my school so that they will be able to capture whatever we shall be able to teach. We cannot say we get a nurse with a D, because then when we're talking about anatomy and physiology and biochemistry and pharmacology, they may not be able to understand. So to that extent, we define the minimum qualifications and together with the regulatory body. We also set standards that ensures that practitioners have the necessary skills and knowledge to provide quality of services to the public. When we look at a nurse administering an IM injection, we will want to know what anatomy do they require, what communication skills do they require, and what are the attitudes that they require. We also ensure professional growth through continuing professional education to update skills of the nurses and midwives to respond to community dynamics. Okay, we drive research with impact. I've said that. We incorporate innovations into the curriculum. We are now talking of e-health, and we are talking now of POCUS, and that POCUS will have to get into the curriculum, and our curriculum reviewed within 3 to 5 years, so we can be able to review and include. But before we review the curriculum, we look at what are the community needs, and then once we do the draft curriculum, we call the stakeholders, like now we are here, so that we are sure we are not duplicating duties, and that whatever we are teaching our students and the graduates will be responsive to the community dynamics. And we must collaborate both nationally, internationally, NGOs, and any other stakeholder that will be able to consume the services of the nurses and midwives. So overview of the nursing training program at the University of Nairobi. Sorry, I will talk about University of Nairobi because that is where I work. We have the BSN Kenya program. BSN in Kenya started in 1987 in Baraton. At the University of Nairobi, we started in 1992. To date, we have graduated over 10,000 BSNs, and we also offer MSNs, Master of Science in Nursing. One of the specialties is obstetric nursing and midwifery. To date, we have trained about 230 postgraduate nurses, of whom some are midwives. We also have PhDs, and we have currently over 20 graduates of PhD. Just to take you back a bit, how do I go back? This one. Okay. So, our vision, like any other academia, is to be a center of excellence in nursing and midwifery education, research, community service, and consultancy with scholars and professionals. And we hope when we do this, we shall be answering to the community problems. Now, we don't train in a vacuum. If you look at this is the policy framework for education and training from the Ministry of Education. What is their mission? They want to ensure that education and training are aligned to human capital development that meets the Constitution of Kenya tenets and Kenya Vision 2030. And now we can add the SDGs, UHS, and the African Union Agenda 2063. So we must look at the human resource. What is the service level? What is the education? What is the research? What are the advances in technology that we shall need to teach our students? What are emerging disease complexities? Like now we have COVID-19 and any other pandemic. How do we train our nurses to be able to respond to that? And the dynamics in the populations. We cannot talk about reducing maternal and neonatal deaths if the mother comes and the services that they get it at that antenatal clinic are not of quality. Because then we shall miss even the fetus with an irregular heartbeat. We also train according to WHO, ICN. ICN is an International Council of Nurses, and also ICM, International Confederation of Midwives, the nursing now, and the WHO. And they talk about global strategic direction for nursing and midwifery. So education here must be able to give people jobs, and those jobs must be useful to the community. They must provide leadership. We know leadership is very important in quality of care, and service delivery must be of quality. And so we believe that when we have this interaction here between what the strategic directions for nursing and midwifery, ICN, Nursing Now, and WHO, and we have healthcare policies, then we shall be able to train people who have knowledge, attitude, skills, competencies, and will be able to do research. And so they will be able to transform nursing and midwifery practice and use evidence-informed practice. You cannot transform midwifery and nursing if you continue doing things that we were doing 20 years ago. And then we hope that they will be able to achieve the SDGs, UHC, Vision 2030, and the rest. Some of the institution training nurses and midwives in Kenya, please forgive me if your name is not here, because this is a slide and cannot accommodate the more than 30 schools that we have for university alone training nurses and midwives. So mid-level colleges are also very numerous. So these are only examples. So nursing and midwifery education, what are the existing pathways? We had certificate. We need to remember that nursing at BSN level started very late in Kenya. So then we had two categories of nurses, certificate and a diploma in nursing, which was called the staff nurse, KRN. And we used to be very important people when you qualify. So, we went to a district and the RN has arrived in town. So now here, we have the minimum entry criteria, which are different for all these levels. But they must pass in English or Kiswahili, maths or physics, chemistry, and biology. So they have different categories, and then they come into BSN. From there, they move to postgraduate studies in Masters of Nursing. And I've said one of the specialty areas is obstetric nursing and midwifery for the University of Nairobi. Then we have the doctoral level. We have three categories here. We have the PhD, we have the Doctor of Nursing Practice, and we have Doctor of Nursing Science. And then we have higher docs and postdoctorates. But then we need to know that here, when we are teaching at mid-level, basically we emphasize on practical skills. I had the opportunity to teach in KMTC before I joined University of Nairobi. So we emphasize a lot on skills. At undergraduate, we give broad knowledge, but we also talk about cognitive and a bit of theories. In masters, now here we have more specialization. Here we don't want them just to be knowledge conformers, but they also need to be knowledge generators. They must know why and what is done in a certain way. At doctoral, we want them to synthesize knowledge. We want them to come up with the systems and be able to change the direction of nursing in the country. So this continues to tell us about different differentiations. We know that masters and doctoral and undergraduates are a bit different, and you can read this from the slides. Training competencies and evaluation we do this all the time. Training requires evidence, yes, we must train knowing that we have evidence that training is effective, and we must use multi-training approach, if I can use that word. And I had said earlier that we must also collaborate. We have what is called the skills lab and simulation lab, which we use for our students before they go to the clinical areas to increase their level of safety to the patients. And we take nursing outside the hospital to the community. This you can see part of our students who are involved in community service, these ones and these ones as well. So we have the theoretical knowledge, written examination, term papers, and knowledge. We have psychomotor skills that you can see here. And in the University of Nairobi, we have the basic sciences. We teach the medical sciences, we teach the nursing, we teach social administration and leadership. And what is the way forward for nursing and midwifery education with regards to POCUS? We are believing that continuing competencies should be evaluated, and I can hear Dr. Mika and Grace have been evaluating. And human resource needs also assessment. We need to check how our people are working. Do they have the right skills, or do they have the skills that they learned 20 years ago? And we need to talk with nurse leaders and healthcare leaders so that they can see the importance of introducing new practices. And I'm happy that the Ministry of Health is here, and they are leaders, and they have seen the need of introducing new practice like POCUS. But we must know that there should be dynamic training or dynamism in training. And this depends on the dynamic needs of the society. And then we must look at environments of training in the various nursing and midwifery. So when we are introducing POCUS from a point of the University School of Nursing perspective, we expect that the trainers in midwifery will be taught so that they can be able to teach the students. It is a cheaper way, because if they teach the students and those students go out and each one of them is teaching 40 other students, then we can teach very many people, the multiplier effect. We need to have regulation in this POCUS, and everybody else has talked about regulation and avoiding duplication of duties. And may I say that it is not task shifting for me, that is my perspective, because if you teach me what I can do, irrespective of who else is there, and refer, for me that is not task shifting. My perspective of task shifting, which you may agree with or not, is you are doing something because somebody else is missing, or because somebody else doesn't have time to do it. Then consumers of nursing will evaluate, and they're the ones who will tell us whether we are providing better services or not, and whether we need to continue. If we are not safe for our consumers of nursing and midwifery services, then we really have no business introducing new technology which is going to hurt them. And the perfect way that I see is that whatever we do need to be tested, effectiveness documented, and move on from there. And thank you very much.
Thank you, Professor. Thank you, Professor Wagoro. No, Prof. Wagoro is a teacher. So, Prof. Wagoro, still the question will be, do we need to train our BSNs on POCUS? All that thoughts. We'll still ask you that question. So, the Kenya Medical Training College is one among the list that Professor Wagoro showed. It's actually one of the biggest trainers of healthcare workers in Kenya, especially the ones who are focusing on for POCUS. And we want to hear from them the same 5 questions. So next on stage is medical simulation coordinator at KMTC, trained as an anesthetist, has skills in curriculum development, research, policy, advocacy, among others. So ladies and gentlemen, help me in welcoming Dr. Wagaki Gisheru. 5 minutes, Doc.
Thank you very much, and good afternoon. Disclaimers, Dr. Gladys. And conflicts of interest. So I have been involved in the training at KU and as an instructor in POCUS. So we did participate under the auspices of GASI, where Sheila was our coordinator. Sheila is a nurse and is also a POCUS instructor. And then before that, I have been involved in being trained and training medical officers, registrars, clinical officers, nurses in the use of POCUS in their practice under the Canadian POCUS Society, led by Dr. Wanjiko Kagima there. So I am a clinician who uses POCUS, and I train others. So now you don't ask me whether I was regulated. Okay. Hopefully I used as a curriculum that is acceptable. All right. So Kenya Medical Training College, of course, this is a nice aerial view of us. The headquarters is there near Nairobi University, between Nairobi University and Kenyatta National Hospital. And we train many cadres of healthcare providers. We have 19 departments and over 90 programs that we offer at that middle level, whether it's short course certificate, diploma, higher diploma. All right. So from a clinician's point of view, and maybe I should also ask Dr. Gladys, because I use POCUS in my clinical care, am I providing ultrasound services? That's a question I've been asking myself when you said that, because I see it as something that I use that helps me in my clinical work to make clinical decisions or to do some procedural skills. As an anesthetist, I do need the ultrasound to be able to see things so that I'm not doing things blind. And now we're moving away from doing blind procedures. People are saying, if you can see, why don't you use a probe to see? So I definitely am sold out to the use of the ultrasound in the clinical space. And so my question, I think, which is what we have agreed, it's not whether we should, but the how. How do we introduce it into our training programs? So at KMTC, we do curriculum. You know, we have a lot of programs, so we do have to develop curricula and utilize those curricula. And our steps are just the usual steps that everybody uses. Yeah, you start off with a needs analysis. You know, do we need to have this curriculum, and who said so and why? And then we look at what kind of learner can be able to utilize this curricula. So even as Prof has said about your minimum requirements, that's a question that we are asking. Who is this person? And then what do we want to achieve with this curricula? And then what can we utilize, what strategies will we utilize to deliver this curriculum. And then, of course, now the implementation, and after that, the evaluation of the curriculum. So this is what we do almost every day. We have a curriculum office with a deputy registrar under the academic registrar, where this is happening continuously, and we have policies around curricula. And so you're welcome to also see what our policies are around that. I want to say a little bit about evaluation. Many of the times we evaluate based on level 1 and 2. Did you like the program? You know, how did it make you feel? What skills did you learn? Rarely do we go out to now do level 3 and 4, which is how have you applied what you've learned in your practice? Because most of the times, because we are a training institution, we release, once you graduate, we release you, yeah? So we don't really follow up to see. We are now beginning to form our alumni associations where we can start to ask those questions, and we have a new alumni office. Then it talks about the skills you learned, how are you using them? And then the other thing is the skills that you learned, how are they affecting outcomes? So we've seen outcomes in the morning where we're seeing maternal deaths and neonatal deaths. Those are outcomes. So what is the link between those outcomes and training institutions? You know, so we don't really there, and I think this is probably a nice space to start asking those kinds of questions. So everybody is showcasing what they have done, like a candid. So of course I must then say that we do have a short course program that's offered at KMTC that started about 4 years ago, housed by the then medical imaging department, the now radiology department, radiology and ultrasound. I forget the new name, but that's the department that has actually been offering this. It's not under the Department of Nursing. And they had this specific program for midwives to come and train in POCUS in midwifery. They have trained 58 healthcare providers, midwives, most of them from the NMS, which is Nairobi County, a few from others. They are not, in the past 2 years, they have not continued to train, and I'll tell you why. But they had, at that point, 200 people who had applied for that course when they advertised. So there's a lot of interest to come for this training at KMTC. Why have they not been able to continue since for the past 2 intakes? Because they have issues with equipment, the probes to be able to use, to train. And then also their model is that the students come to the classroom and use a mannequin. So they do a lot of simulation before they're released out into the field. So that mannequin aspect is what also has been, it was donor funded initially that came with the mannequin, and then sustainability issues. Then the mannequin was taken by the donor. So what do we do now? Because that's the model of their training program. The other aspect about that training program is that you come to KMTC for that hands-on knowledge, physics. They are confident that you know how to generate an image, and then you go out for 4 months and you're supervised by somebody in the clinical area. Most of the times it's a radiographer who's done sonography. Then they would be supervised as they make those decisions. I asked them what are the areas that they train on, and it's similar to what we were doing with gas. It's similar to what most people do. It's usually binary questions, usually the 5 areas: fetal heart rate, amniotic fluid, presentation. Those are the questions, and those are the things that they ask them to be able to generate images around. What are the potential areas that KMTC could get involved in? We do have a midwifery program, the Kenya Registered Nurse and Midwifery, that is offered in some select campuses that I think POCUS could be a very nice way to introduce as a starting point. Of course, we do have our higher diploma programs. The clinical officers are now being trained in reproductive health, and we have training. We had a training in Kenyatta a month ago where we got some of the trainers at KMTC, what we call course coordinators, to come and experience POCUS and see how they can utilize it in their clinical practice, as well as incorporate it into their training programs. what are some of the barriers that I have found? A lot of medical schools and medical curricula are having this same conversation. They want to introduce POCUS in the medical curricula at undergraduate level. So, and these were some of the things that people have found as the barriers. One is funding for first curriculum review, then the educational programs and the funding that they need around that, then trained faculty. POCUS is an interesting thing. It's not just ultrasonography. It is ultrasonography or the use of an ultrasound in a clinical context. So if you need to have somebody in the clinical context who is utilizing that ultrasound and for their clinical decisions to be able to provide, I don't know what I did, to be able to provide that care and mentorship. Okay, so it's great to have a sonographer to help you generate images, but you still need to go back with that image and say, so what do I do now? What next? Okay, so clinical care is important. Then there's the aspect of already our curriculum, when the nursing council you take and it's a 3-year program, every hour is accounted for. So now when you want to do something new, you have to figure out, what do I reduce or do I extend the time? So crowded curriculum is another thing. Then there's culture. And I think some of I think Dr. Grace had brought that up. When you go into the clinical space and you whip out your ultrasound, is there a culture in that healthcare system that allows for you to use that? And it can be incorporated. So that if you check and you see that the fetal heart is slow and you need an intervention, that is acceptable at that level, and that other people can say, oh, really? Show us again, and they look and say, yes, we need to do something. So this culture is an important thing. Even when you're sending your students who you have trained to go into those institutions, what do they find there? And then, of course, there's equipment that everybody has said about. It's expensive, you need maintenance, insurance, all those things. Data protection, so there's many other things I can put inside there. So what are my final thoughts? That integration is great. We need to get there. But we need to have careful thought on the how to do it. Then the other thing is that we need to see POCUS as what it is in the clinical space. So you match the objectives of POCUS with your educational objectives. So if you want your student to be able to identify a fetus that is at risk, that's the educational objective. How do the POCUS objectives integrate with that? And then the last thing is that now with this conversation, will this be the catalyst that finally gets us to that point where we do have that ultrasound probe at the bedside for a clinician to use? And thank you very much.
Thank you. Thank you, Dr. Gisheru. You've saved us a few minutes. The next presenter, who stands between us and lunch, wears many hats from academia to professional associations. He's an obstetrician gynecologist by training. He's an infertility specialist, lecturer at University of Nairobi. And he also doubles up as the president of the Kenya Obstetrics and Gynecology Society. Ladies and gentlemen, again, help me in welcoming Dr. Kireki Omano on stage.
Good morning, ladies and gentlemen. Mmekubali ni asubuhi. So it means we are not very hungry, which is good, and I promise you I'll not be here for long. Thank you, Dr. Serem. Thank you for the organizers to invite us. I only have one caveat that we have the president of FIGO in this country, and she was not invited. Organizers, tafadhali. So, having said that, thank you for this invite. About 3 months ago, I had just finished a procedure in one of the private hospitals. And as I was going to change, I was called by one of my colleagues who is an anesthetist. And he said, come to theater, I think it was theater 3. Ebu jo haraka sana. There's a serious PPH there. So, as it is, rushed there. I saw my colleague was struggling with this patient. Notably, this was a patient who was 30 years old, her first pregnancy. Delivered a beautiful baby girl, and she started pouring. Those ones of us who are obstetricians know what it means, Ganda and Guaco. So 2 heads are always better than one. So I said, okay, let me check again, or have you done 1, 2, 3? Of course, there's some things which we do without thinking, reflex action. Have you checked the vagina? Yes, it was a small tear, really, two sutures, and everything was sorted. The cervix is complete. There are no tears, but she is pouring like there is no end to this world. And we would put in an abdominal pack, and after 2 minutes, it will be completely soaked, and come out again and push back another one, trying to find out what the problem was. Obviously, the uterus, that's the first thing that we do. Uterus is well contracted, so where is she bleeding from? There are no tears, and so on. So I inserted my hand into the vagina, and at the back of the uterus, I felt as if there was something there, probably a fibroid. And my take was that that is where the problem was. The placenta had been on top of the fibroid. It had come out. The uterus could not contract at that particular moment, at that particular place, so she was just pouring. Guess what saved the day? It was not POCUS. It was a condom. Yes, not Automishtuka. It was a condom. We asked, do we have a condom? Do we have anything? And of course, there was no condom. Can you imagine? There was no condom. And then this lady, a nurse, goes out, walks around a bit, comes back after 2 minutes. Meanwhile, we are sweating. She's pouring. And you see, we have asked the anesthetist, umempatia oxytocin, I've given, misoprostol, I have given, even ergotamine we have given, but she's still pouring. And then the nurse comes and says, by the way, this was not in my pass. Not that it mattered anyway, wherever it came from. So what we actually did, we improvised a UBT, uterine balloon tamponade. We inserted it, pushed in some fluid, about 200, 300 mils, and it stopped bleeding. Just to make sure, we put in another abdominal pack, 2 abdominal packs, and by the way, while we are doing this, her pressure was actually going down. You know, you can say a tick, 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 tick. So when it stopped, we said, "Wacha ikaya hivyo." She was sent to ICU. And guess what, ladies and gentlemen? Her pre-delivery HB was 11.7, and when we took her to ICU, it was 3. She was actually going to be a statistic. But again, women are very resilient. Hats off, ladies, all of you. She received what she needed. That was on a Friday. On a Monday, she went home with her baby. Walked out of hospital. Today, we are talking about POCUS and having an impact on our maternal mortality rate, direct impact. Our maternal mortality rate, for those ones of us who may not know, is about 364 every 100,000 women who deliver. Other sources will say 355. Whatever it is, whether it's 355, whether it's 364, it is way too high. We are losing over 3,640 women for every 1 million ladies who deliver in this country. It is unacceptable. Absolutely unacceptable. What COGS is doing for this month, we have called it a PPH month. We've actually been talking about this in the media and all over. I've been in the TV. Today I was actually in the radio. Was it radio? No, Radio Citizen in the morning, trying my Swahili, and I hope it came out well. But this is what we are trying to do. Even when you talk to the journalists, they are shocked about the numbers. How will POCUS have an impact on maternal mortality rates? It's not very clear. Because this lady who came in the private hospital, she had actually had 3 scans, but she still had PPH. Will this have an impact? We need to see it. We have talked here, Dr. here has talked about data. Do we have data? We don't have data. We need that data. Now, the interesting thing is that WHO says that every pregnant woman must have 1 scan before 24 weeks. So my question is, from where I sit, Is this poor man's medicine? Or is for everybody? It cannot be for everybody. Because in other places, in the US, for example, American College of Obstetricians and Gynecologists, the Royal College of Obstetricians and Gynecologists actually does not even talk about WHO one scan at 24 weeks or before 24 weeks. They have a standard 3 scans during pregnancy, and there can be more depending on a case-by-case study. So why should we hold on that it has to be 24 weeks or before 24 weeks? Okay, if it is before 24 weeks, fine. Should we do it at 11 weeks plus 3? When we do the anomaly scan and we look for the nasal bone and we do nucotranslucency, should we do that at between 18 and 22 weeks when we have to look at the baby's heart and see whether everything is okay? When should we do it? So I think from where I sit, we need to have a Kenyan standard, not necessarily a WHO. We can incorporate what WHO says, because 24 weeks is very confusing. If it were my wife who were pregnant, and this is the standard that I use, she would have 3 of them, just like other people have it. And to tell you the truth, wazungu wanajipenda. Mupende msipende, wazungu wanajipenda. That is why they do 3 scans or even more. Is POCUS something that can be used to enhance the quality of care in our mothers? Absolutely. Absolutely. But then the question we need to ask ourselves, who, number one, is going to be trained in doing POCUS? Professor has done a fantastic job. Who is going to be? Is it the diploma nurse? Is it the registered nurse? Is it the BSN nurse? Is it the midwife? Clinical officers, that is fine. And somebody else who is not here, where are the doctors? KMPDC? Where are the doctors? Because here we say, clinical officers, we are doing this to enhance, maternal mortality, to have a direct impact on our maternal mortality rates. Where are the doctors? The doctors must be at the center of this conversation. And not only doctors, consultants themselves. Most of the time, we are consumers of these scans which are done by other people. And I'm sorry to say that sometimes these scans are, let me leave it there. So we need to be careful, number one, about whom we are going to train. What are they going to be trained on? Are they going to be trained right from the word go, 11 weeks, 11 plus 6 to 13 plus 6? Then they also do the 18 to 22 weeks. Then they do the 34 weeks. Are they going to do that? Are they going to look to focus on that 18 to 22 weeks, since WHO wants us to have 1 scan before 24 weeks? How long is the training going to take? Because as Professor said here, the training is a hands-on, you need to do it, but there is a steep learning curve. Where do we start from? The issue of standardization came up, and this is something which is imperative and it is important. We must standardize. We must standardize reporting. We must standardize the way these scans are done. We must standardize what we get. But then the question also comes, when I send my patient for an ultrasound scan, the ultrasonographer has no idea about the clinical history of this patient. So how do we merge that clinical history plus what the ultrasonographer is seeing, and then comes up with a result which we think is reliable? Unfortunately, most of the time, the results we get are unreliable. I work in KNH. During the ward rounds, we say end of a new scan, and sometimes the scans we get have a lot, leave a lot to be desired. So standardization is important. Who is going to do this? In Ghana, for example, I met a friend of mine from Ghana who is a radiologist, nota bene. They have a BSc degree in ultrasonography, which is very good because it just focuses on ultrasonography and nothing else. Does that take food away from the radiologist? I don't think so. will these the people who will be doing the POCUS, will they take quote unquote food from the radiologist? I don't think so. We are here to converge in a nexus in order to help and provide quality care to our patients. And by the way, reproductive health is the only branch of health which is in the Constitution of Kenya. It is the only one. So it is upon us who are here today and who are not here today to make sure that we actually help these, our mothers. Lastly, how are we going to regulate this? My colleague is here, Dr. Mvugwa. We have clinical officers, we have midwives, we have nurses. All of us have different sort of pathways. So who's going to regulate this? And how will it be done? Because the clinical officers will say, I belong to the clinical officers. The medical officers will say, I belong to the Kenya Medical Practitioners and Dentists Council. The midwives will say, I belong to the Midwifery Council. And the nurses, we are nurses, and we have nothing to do with clinical officers, nothing to do with doctors, nothing to do with midwives. And then we have a mishmash. So I'm very glad that Dr. Serem is here. I think you have a lot on your plate when it comes to this, but I think that will not be impossible. With all the brain power in this room, we can actually harness this energy and focus it on helping our mothers get quality care. And hopefully by doing that, we'll have an impact on the horrible numbers that we have of our maternal mortality rates. 2030 is not very far away. SDG 3.1, reducing maternal mortality rates to 70 out of every 100,000. Will that be done? I leave that question to you. Is it possible? We need to harness all the energy that is possible in order to direct it in that to that problem. Abidjan Declaration was that in 2015, and Kenya is a signatory that we are supposed to get at least 15% of the budget into health. I think now we're about 10 or 11%. Will we get there? Hopefully. And we do hope that by the time we get there, we'll have reduced these numbers. And then lastly, when you talk about who is going to do this, there is a question I always ask my students when we're doing a ward round, labor ward round. What would you do if this was your wife? Would you prescribe the same treatment? Will the management be the same as what you're saying? And immediately I ask that question, there's always a change. Oh, my wife? No, my wife would be different. My sister, it would be different. So as we're sitting here today, will we be happy with the training? Once we have trained this cadre, will we be happy for them to do a scan on our wives, on our sisters, on our mothers, and we'll be happy about the quality? Dr. Mwango is here. That should be the bottom line. If you're going to train them, let us train them in such a way that I'll be happy to actually give them my wife. Yes, you can do that scan on my wife, and I will be happy with the result. That will be the success. But if we train them just to go and do scans, we have missed the point. Thank you.
Thank you, Dr. Kireki. So for the next 10-15 minutes, I think we'll do a Q&A. Charity will take us through.
Okay, so we'll invite all the speakers from the two topics to please come to the front. And then I'll ask you to prepare your questions. I'm ready with them. Please come forward. So I had a long list of questions here, but I'm going to set them aside in preference for your questions. I think if we can hybrid that also. So I had questions on artificial intelligence and the ethics of that and the regulation, and I had questions on general quality assurance. So if somebody has a question on those two, we can start with those two. Somebody had a question on quality assurance? Okay.
I think, yeah, I think mine is not really a question, but a clarification that when we're talking about POCUS, this is a continuum of care of what the midwife, and I'm glad someone raised the issue of the medical officers and the clinical officers are traditionally doing. We are trying to make that better. So how do we prepare them for that? This should not be a replacement for an obstetric scan, which should continue to be done as per the standards that have been set by Kenya, WHO, or whichever standardization body that we are using. So I'm hoping that we can have that clarification as we continue with the conversation, so that we don't imagine that we are training the midwife to take over what was previously done, and that should continue to be done. Thank you.
All right, there's a question in front of you.
Yeah, I think I'm going to just drum that point again. And for most of you sitting there, especially Wagaki, you know, when we do point-of-care ultrasound in a patient with fluid in the heart or lung, I'm not doing it on every patient walking in. I basically select. So if I have a very breathless patient, I examine, and I feel that this patient is probably very sick. I need to know what's happening. That's when I do. So I think the clarification I need from the panel is, are we telling the midwives, do point-of-care ultrasound on each and every woman who walks in, number one? Or are we telling them to self-select, like if the patient has come and has a problem, that's when they can scan? The second question is, and this, I don't know the answer, probably the radiologist and the obstetricians can guide, is it necessary to do positioning at 24 or before 24, fetal position? Because we've seen the curriculums that have been used, and they have like 5 common questions. So at what point in the gestation is what important? I don't know whether you're getting my point. So is fetal lie important before 24 to an obstetrician, to the consumer of the scan, or to the radiologist? Or should we train them for the second trimester? Like we said, 24, is 24 second trimester? I think so. Or should we train them for the third trimester? So one, who to do the POCUS on? Number two, if you were to roll these out, would you, what do you tell the midwife? Do you check certain things at certain gestation? Then the last thing I had is, in terms of, this is to Mbugua, Dr. Mbugua. I don't know whether, as Daktari has just plainly put it, I don't know whether KMPDC is enough for regulation. I doubt, because this is a field that everybody is in on it now. We're not only having midwives, it's not only in obstetrics. In pulmonology, we do POCUS. Cardiology, we do POCUS. Rheumatology does POCUS. Anesthesia does POCUS. And now, even in medical subspecialization, endoscopy is using ultrasound. And all other subspecialization, like in pulmonology. So, who really sits on the table to regulate POCUS? And I think this is to Mwango and Mbugua. Would it be possibly a multidisciplinary team with all these people who have POCUS? And the other thing, to Mwango, nakuchokoza, you said ultrasound cannot be limited. I don't know about obstetric ultrasound, but I beg to differ for others, because when I do POCUS in my field, I'm basically looking at, is there pleural effusion? Yes or no. I'm not wanting to diagnose other things that are all over the place. So I go in with a very, very clear question. Does that qualify for a limited scan? In obstetrics, I don't know. But is there a form of limited ultrasound in obstetrics? Sorry, I'm holding.
So, right, let me start with the last question, and thank you very much for the questions. The context I was talking about, we cannot have a limited ultrasound scan, is that if this pregnant woman is coming for just one ultrasound scan as per WHO standards, then it should not be a limited scan. Let it be a comprehensive obstetric ultrasound scan. Then you can get as much information as there is. But this also brings in the issue, what you brought in. How are we defining POCUS in this meeting? I think we are having different definitions of POCUS coming up. We're having definitions of, I'm using POCUS as part of my clinical examination, whereby the healthcare worker has a pregnant woman coming in and they want to know the lie, just a few basic things. That's how there's that definition. But the real definition of POCUS is actually that ultrasound that is done, usually in an emergency setting, to look for something particular, for a specific action, and which will lead to a specific action. So like what you're talking about is the more POCUS, the maternal POCUS. So you're looking at the circulatory support, cardiopulmonary support of this patient. So the patient comes in, and you know sometimes they could have other comorbidities that are going to cause maternal death as of separate from the pregnancy. And that is what now you need now to evaluate. Is the patient dehydrated? Is the patient anemic? Is there pleural effusion? Now that is very focused, very limited. Emergency physician, again, also use POCUS. Again, very specific things they look for. And to help them to make an action, to do something about it. So there are different definitions. And when we talk about we need to standardize the curriculum, that's the first thing that we need to do. As Kenya, what kind of curriculum do we want? How do we want to do our ultrasound practice? And we have to really regulate the entire ultrasound practice, right from the very beginning to now, the different levels and the different cadres, because we have everybody doing ultrasound. We have the cardiologists doing ultrasound. We have in ICUs, again, ultrasound is being done. You can look for a pneumothorax using ultrasound. In newborn unit, the same thing. So we need, and all those will be our POCUS. Ultrasound at the point of care, which is different than ultrasound at the primary healthcare level. And I think that is where the confusion came in. Yeah. So the ultrasound at the primary healthcare level, can we make it a comprehensive ultrasound and figure out how we are going to go about it? Now, when we look at obstetric ultrasound in terms of our curricula, there are different things you look for at each trimester. So in the first trimester, you want to know, first of all, is there a pregnancy? Is it in the correct position? And you do some dating, you know, and exactly. And how many are they? You know, things that can actually be very important, you know, that kind of thing. Is it also normal for at that age? That sort of thing. Because it could be a H-mole that you are dealing with. So there are all those abnormalities that can come in. In the second trimester, that's when now we do the fetal anomaly scan. And I think that's kind of like is what the WHO is talking about. And you can have an idea, you know about the presentation, but it can change towards the last trimester. And again, the one done at 36 weeks is the one that really guides obstetrician on how they're going to deliver that patient. But then you should know that really there's no placenta previa, and this is how the presentation is and all that. And that's why now we can now do other things, like are we able to do a biophysical profile and things like that. Yeah.
Thank you. So, kidole kimoja hakivunji chawa. Right? For those who don't understand the Kiswahili, it's just saying with one finger you can't, you know, kill is it a flea? The lice. So basically, I agree with you. KMPDC cannot handle this space alone. But KMPDC cannot be left out of this space. We regulate the healthcare professional, the doctor, the specialist, all those specialists that have been mentioned. We work with them in developing core curricula, including for training the radiologists. Yeah? So I believe that KMPDC, mandated by CAP 253, cannot be left out of this conversation. That said, I believe the other regulators as well need to come in. When looking at the curricular review, the Ministry of Health had guided us to call upon all regulators and ask for their core curricula. You will be surprised some don't have a core curricula. So we are talking about developing from scratch a core curricula, which I think is not so bad because you get now a chance of doing it right. Yeah.
Yeah, thank you so much. Very short. Just to add on what my colleagues have talked about, is that we are talking about the scopes and the operationalization of it. But from my end, I'm thinking there's need for a very strong policy document that can guide a lot of operations. And when we look at the healthcare system, we have different cadres and professionals. And during the training, then I don't think the training may be, it needs to be standardized. However, the depth and the breadth of how the operation should be done will be different. I'm talking from the point of view of a midwife. For us, it's an assessment tool. Just the same way someone talked about the fetoscope and the Doppler, then that is just to measure limited number of modes, just the 5 basics. For anything that needs more than that, then that is a decision-making tool to help us refer for something that you don't know. So I think issues of regulation also will depend on the regulating body. For the nursing and midwifery, we already have, it is embedded in the curriculum for the basics. It is also embedded in the EMOC, which is the emergency maternal neonatal care. So maybe moving forward now is, when it is made for all, then it needs to be relooked into so that it depends on who is the person being targeted. Is it the midwife? Is it a doctor? Is it a clinical? And where are they practicing? Because for me, in the labor ward, when I want to rule out something real quick, then something I cannot palpate. I may not be able to choose for all women who are coming to the labor ward, but I can specifically use it as an assessment tool to be able to check into what is it that I'm not very sure about. Maybe the placenta is lying low, and this woman is actively in labor, and I'm seeing something that needs to be just a quick assessment tool. So I think the scope will depend on the profession, and also the issue of need for standardization and regulation also, as people have talked about, will also depend on the profession. However, there should be that high-level regulation that will now guide the operation of that. And the other issue also is the legal parameters under which this will be secured. We talked about the AI. It's a new thing in our space. So there will be a lot of things. And we are very curious. When I got that POCUS machine, I wanted to know everything about it, all the things that needs to be done. So there must be a regulation that will deal with that. And also issue of understanding our cultural space, our ethnicity. That is something that we do not overlook, because we also have issues that need to be considered in terms of responsiveness. So I think the conversation can continue, but we need to think wider, look at the end as we now process the path under which we are taking. Thanks.
Thanks. I have one question, maybe, or maybe it's a comment. Typically, when you go to the health center or dispenser, that's where we want to take healthcare to, not to Kenyatta or Jaramogi. That place usually has 1 nurse or 2 nurses. And so all of us are very good at protecting our area. We need a mental health nurse, we need a physiotherapist, you need a doctor, you need a lab person. You will not have 6 people seated in a dispensary to take care of 20 people. It's not cost effective, it won't work. And so task shifting is not going to be going away anytime soon. This nurse who is there will have to be trained to know this person has a mental health illness, needs to be referred. This one needs a serious ultrasound. And so that's why we're talking about point of care ultrasound for primary health care. And what does that mean? The comprehensive 24-week scan. There's something in epidemiology, or is it in public health? Number needed to treat or number needed to harm. How many ultrasounds are you going to do to diagnose one, maybe spina bifida or calta or something like that? What we need are things which are disturbing us. Oligohydramnios, placenta previa, big things, which the point-of-care ultrasound and the AI can be able to do. So if we are able to do those things now, because we do not have an obstetrician or a sonographer at the lowest level, then it is perfect. So for me, the point-of-care ultrasound should be used. What is the nurse palpating at 12 weeks, 14 weeks, 18 weeks, 12 weeks, and then cephalic and go away? Very little information. So for me, the point-of-care ultrasound, if you have it, do it on everyone who walks in there. What's the problem? The machine is there, the AI is there, and all you need to do is scan, and it will tell you there is a problem, refer. So we are thinking about using it to screen the people who need to be seen at higher levels, not to diagnose. And so it should be left open to everybody. People in other countries, they're even giving community health worker, the ultrasound probe, community health worker, to go to the community and scan and say, this one is a problem, you need to go up there. And then finally, the training. We love training. In fact, we're even trying to see how do we cut down on training. Because one nurse who is in this health center is being trained 1 week. Today we want to train you on ultrasound. Tomorrow, the guys of mental health are coming. Everybody is coming to train you, okay? And so what time do you work when you are being trained? By the time you finish 2 years later, you have gotten a new job, you've gone away. We start again with a new set. This is why we are saying this idea of overtraining is not useful. We need to leverage on technology. We need a 1 day, 2 day training. Put this scan here, do it like this, do it like that, do it like this. It will give you an answer that this is good or this is bad. That's all she needs to know. Bad, refer. Good, come back next day for your next clinic. Thank you.
Yeah, thank you. My name is Dr. Stephen Ojwang. I'm a radiologist by profession, but I'm here on behalf of the Rural Private Healthcare Association and Kenya Healthcare Federation. So on matters quality, I'll give two scenarios. Just to answer your, maybe also to respond to what Dr. is saying. So the other day, we got a patient from deep in the Mara. I was called at about midnight. She couldn't, this clinician there who I know very well, is very good at his work and he couldn't feel the baby was not moving. The mother was complaining that the baby is not moving. And we asked him to check, and there was epigastric pain. So we asked him very quickly to check the blood pressure. The BP was elevated. She had PET, which was undiagnosed previously. So very quickly, they were brought to Narok at our facility there. And we were able to help them in terms of onward care. But I can't count for you the number of hospitals they passed, starting from the first point where the baby was seen, which easily could have handled because it was a PT case and they had the capability to be able to handle that case. But they couldn't do the ultrasound. And they passed about 4 or 5 other facilities. Now, the other tragedy is that, I'll give the second example. We had, we've done some work in Loitoktok, which is about 4 hours away from Nairobi. And there's a day we had a lady who went there, and at 8 a.m., she went there to beat the queue. So because of the queues, and because Kenyans, we think the same, she was seen at what time? At 3 p.m. So she leaves Loitoktok at 3 p.m., comes all the way to, sometimes I work in Kitengela. So came there, and because it was too late, she spent the night, slept, booked accommodation. The next day came for the Doppler scan. She had a swelling in her leg, and we were then able to help her. But remember, she had spent 4 hours, a whole day, wasted the previous day, because there's nobody at that time to do the scan in Loitoktok. Now, most Kenyans, if they're like me and you, they come with their relatives. So that means these are 2 or 3 people who are not working. That's a whole reproductive day that is wasted. Now, so the lady, to make it worse, the cost of the logistics, I did the math, looked at the cost of the transport and time, and also looked at the cost of the accommodation. It was even more expensive than the cost of doing the Doppler itself, the actual help that she needed. So these are real situations that we're dealing with. And I think as we look at the conversations around quality, we also need to be very practical. The private healthcare space plays about, we see about 50% of the patients within the country. So I'm glad we are here and we need to be in the conversation as well. But think of that patient out there who needs that quality assured. We've had two areas that that there's a bit of a confusion, and I'm glad Dr. Mwango and the team have clarified. There is point of care ultrasound, which is done by various specialists, and specialist here doesn't mean consultant. I was trained by a nurse practitioner at Aga Khan to do ultrasounds, and she did that very well. So how do we separate that point of care ultrasound vis-a-vis the screening ultrasound at the primary healthcare level? And what are we saying? How do we segment that? It has to come out very clearly, because people are dying. That's a reality. People are suffering. If that lady, we hadn't sorted her out, thank God she had a clot, by the way, but luckily she was able to be helped. So this is a real conversation. I think it's a multidisciplinary approach which needs to be adopted. As we think about our professions, let's also think about that patient out there whose life needs to be saved. Thank you.
Thank you, Dr. Ganda. In my mother tongue, I would have told you I've stolen words from my mouth. Let's think primary healthcare, primary healthcare, primary healthcare. That's why I think we're here. It's about people in the lower levels of the health ecosystem who have no access to the referral hospitals. Let's think about that. Let's think about continuing professional development, CPD in POCUS. We are not discussing a core curriculum in BSc ultrasonography. No. We are discussing continuing professional development, giving people value-adding skills to be able to mitigate on the killer risks. Let's think killer risks that our pregnant women, our sisters, our mothers are facing in the lower levels of the health ecosystem. The other advanced aspects, let's leave them to the academia up there to deal with it. But for now, let's how to do so. My last comment is to Dr. Kireki. The studies which are out there, they have shown very clear that ultrasound screening alone does not determine a pregnancy outcome. There are many other factors which determine an outcome of a pregnancy. But it has shown very clear that it is helping identify the risks and mitigate on them early enough and prevent that woman from dying of a preventable death. My last comment I was to make is on the curriculum, because that question came earlier from the moderator. The curriculum we have used in our pilot projects, it was done consultatively. We had Radiographer Society of Kenya, in that design workshop. We had the Nursing Council of Kenya and the training institutions in designing the pilot phase curriculum. So we had a stakeholder engagement. And as we are thinking this curriculum, because the questions have come from the floor many times, let's think across cadre curriculum. Let's avoid creating several 15, 16 curriculum because we want to protect our professions. Let's have a cross-cadre CPD curriculum, which has maybe modules, several modules. You can even say module 1 to 4 is for nurses and midwives. Module 5, 6, 7 is for a medical officer. But it's a cross-cadre curriculum. That is the way the world is going. We are not doing, one curriculum for every profession. That is a wastage of resources. And lastly, remember, the definition of a midwife has changed. I'm thinking as looking at a midwife as somebody who left KMTC after getting some C+, didn't go to university. No. At the moment, a midwife is anyone who can give skilled pregnancy care and skilled birth attendance. It could be a medical officer, could be a surgeon. We have surgeons who are midwives by virtue of the skills they have. So we are discussing how do we make whoever is touching a woman have the essential skills of screening that woman and pick a killer risk that is going to make her, become a statistic. Thank you so much.
It's my turn? Yes, I've been told to make a quick comment. And my comment is that we must get away from a mentality of scarcity. Because the reason professionals fight radiologists versus the next thing is because we do not realize that we have 50 million people to look after, and the biggest challenge is that they don't have enough money to access healthcare. We are not enough. All of us are way, way inadequate if every Kenyan could afford healthcare. So we need to move away from scarcity and think about getting more people to access healthcare. My second quick point is that training is about apprenticeship. Titles should not be the key guide. Can you safely do an ultrasound? And if you can, it really doesn't matter what your title is. We should license you to do it. My final one is that we must focus, and I think that's what my brother is talking about, patient-centered care. So that we are, because our system is provider-focused, radiologists, gynecologists, we must shift to patient-focused care, because that means we provide care as close to the patient as we possibly can. Thank you.
Thank you very much. I have about 5 hands that are up, but unfortunately time is finished. And there are many people that walked in this morning and told me, I have surgery at 4, so we have to finish. So please allow me to let you continue the discussions over lunch. I will ask our moderators, to our facilitators, I'll give you 10 seconds each to just say final remarks, and I will be counting. And please allow me to take the microphone away from you so that I can do justice to everybody. Simenikubalisha. Thank you very much.
You should have made me the last. Okay, mine is to let us just contextualize this and be as realistic as possible. I will not expand, but let us be realistic.
Thank you.
Mine is to appreciate the conversation that we are having and to pose a question. When we do use this point of care ultrasound, God forbid something goes wrong in the healthcare facility, who do we hold responsible?
Thank you for the time.
Thank you very much. To answer the questions that have come from my colleague there, I think it is important to do these ultrasounds. Yes, it is important to offer service. Yes, but let us focus on the quality, not just for the sake of doing it, because that will be poor man's medicine. And let us move away from there. Thank you.
AI has come up quite a bit. And at KAR, we do have a position paper on AI. Now, AI is useful to help the clinician, the physician. It does not work on its own. The person who bears responsibility is the physician. And that has to be very clear. It's not going to be that AI tool. Thank you very much. Currently, we are doing those programs where anybody can come and do. I am of the opinion that if we can have POCUS as part of educational objectives in the programs that we are already running for midwives, for nurses, for medical officers, it will bear more fruit. Why? Because we teach those clinicians to make decisions in a clinical setting. If they can then incorporate the ultrasound in their decision making, then we'll be making some good headway.
Yeah, thank you very much. I want to talk about 3 things. 1, training in undergraduates and postgraduates. It's important that we train them. 2, about duplication. We are talking who will do what. And I want to assure us we have midwives, we have obstetrics and gynecologists in the labor ward. Nobody takes over anybody's task. They all work together. Number 3, let's think about POCUS as BLS or ACLS, which is done by multidisciplinary teams. Thank you.
I want to use the word obedient panel. Thank you very much for keeping the time. Let us appreciate them. Asanteni sana. Actually, we are going to take a group photo before we break for lunch. So I would like to invite you all to the front so that we can take a group photo. After that, please collect your meal card on your way out. We will be back after 1 hour on the dot, and the 1 hour starts now. So the faster we do the group photo, the more we can take the questions and the discussions that came up. Karibuni sana. I want to say there'll be the last person will dance for us. So ule mtu atafika mwisho atadance. Kujeni. Alafu wenye picha tupange. The photographers, please arrange us very well. There are some people standing there at the back. Backbenchers. All right, chakula inapoa, chakula inapoa. Tukuje tupigwe picha. Hai.
Hapo itakuwa very impossible. Watu ni wengi. So tungepiga pale. Let's move all the.
Mimi niliuliza nikaambiwa ni hapa. Sasa ona nimeshausema. So we do what? This is in.
Can we go outside?
William, wapi?
Hapo nje chini.
Ona washaji.
If not that, I have to move all these tables behind.
Not all of them, just this one. Right? Do you know, you will not manage to get them back down there. Do you think so? Me, I don't know how to do that. I've already managed now. Let's go. Let's move this. Let's push this.
I don't have
I'm gonna get it today evening. Probably I can see you on Wednesday. Yeah.
You arm your company with the most powerful server hardware you can, but now 125
I'm a single mom. I went to two hospitals. One, they told me 1,200, one 1,500. So I just went back home, yeah, and hoped for the best.
We always say no mother should die giving birth.
In sub-Saharan Africa, women have some of the highest maternal mortality rates in the world, and that's mainly due to lack of antenatal care.
Having easy and ready access to ultrasound can reduce that maternal mortality.
Point of care ultrasound, to be specific, is a medical practitioner, a nurse, a midwife who has a probe and is able to assess the patient.
With the Gates Foundation, we are deploying 1,000 probes, 500 here in Kenya and another 500 in South Africa.
We're really excited this week to launch the 1,000 Probe project, where we get to train our first cohort of 50 midwives to learn point-of-care ultrasound for basic obstetrical indication.
Mohammed Hassan from Butterfly. So I know they are prepared to give presentations, but I'm going to give them at least 3 minutes each of them, 3 to 4 minutes each of them, so that they introduce to us who they are in less than a minute, and then tell us about their product or the point of care ultrasound they manufacture, and tell us something about what other innovation is there in that point of care ultrasound that they have. Just shortly in 3 minutes. And I'm going to start from my extreme right with Mohammed Hassan. Mohammed Hassan works for Butterfly. He is a general manager for Middle East, Africa, and the Butterfly Network, a company that's revolutionizing medical imaging with its innovating handheld ultrasound device and cloud-based platform. With over 15 years of international experience in the medical device and software industries. Allow me not to read everything about you. They will feel you as you speak. So Karibu, maybe you can give you the microphone to give us your 3 minutes. I know there was there was a video. Is the video ready? Is it ready? Okay.
Thank you so much. Good afternoon, everyone. This is my first time in Kenya, Nairobi, and I'm so privileged to be here with you and to learn the whole morning your vision about the future and how you see optimizing on quality of care here in Kenya. Been working with Butterfly 2 years now, focusing on Middle East and Africa. I've been touring a lot of African countries, and please understand that it is not only your problem. It is out there everywhere. And I'm so proud that you are allowing everyone to sit on one room and exchange ideas. But I'd like to start with a quick video about what Butterfly were able to achieve in the last 12 months here in Kenya with the aid of Gates Foundation and our partner, Kenyatta University and GASI, and the training. So please run the video. Thank you.
I'm a single mom. I'm a single mom. I went to 2 hospitals. One, they told me 1,200, the other one 1,500. So I just went back home, and hoped for the best.
We always say no mother should die giving birth.
In sub-Saharan Africa, women have some of the highest maternal mortality rates in the world, and that's mainly due to lack of antenatal care.
Having easy and ready access to ultrasound can reduce that maternal mortality.
Point of care ultrasound, to be specific, is a medical practitioner, a nurse, a midwife who has a probe and is able to assess the patient.
With the Gates Foundation, we are deploying 1,000 probes, 500 here in Kenya and another 500 in South Africa.
We're really excited this week to launch the 1,000 probe project, where we get to train our first cohort of 50 midwives to learn point of care ultrasound for basic obstetrical indications. We are working with Global Ultrasound Institute, and we are partnered with Kenyatta University.
It's not as complicated as a big machine, and it's portable.
It is simple to use. It was very easy. As they become better and better, they will be able to train the other midwives.
It has changed the way I think about ultrasound. It can assist in making some very urgent decisions.
The Butterfly device, I love it personally. I can competently say that now I can do a quick overview of a mother who is pregnant.
This, I think, will go a long way in helping us do very quick referrals to a comprehensive facility.
Each Butterfly, if it's used multiple times a day by these 500 midwives, that will be tens of thousands of patient interactions. There will definitely be lives saved.
I've been able to see the heartbeat. I can see the baby moving. I can see the head.
It's so happy. Somebody saying there is a chick. You've never seen a chick inside your belly.
You are much stronger to know that you have a surviving thing inside you.
Maybe if you hear the name for the first time, Butterfly has invented the first ultrasound on chip, which is making us able to put 3 probes on a single probe, which means you can scan whole body with a single probe. It is a device that can be plugged into any smart device, whether it's Android or iOS. And with that, you are able to use something so easy to navigate based on organ presets. Instead of learning neurology, instead of learning to adjust the presets, we have done this to make it easy to use. The probe itself is made out of aluminum case, so it's robust and durable. It is water resistant and dust resistant. And as I said, the chip here makes it more affordable and more durable to work at point of care ultrasound. So that's pretty much from my side.
AI, anything?
Okay, so if I have... So this is on the hardware level. Of course, the software comes loaded with a lot of applications. As I said, we cover a lot of clinical applications from eye to toe, and we have AI application that are diversified in the sense we can help ease identification of needle in the body when you do vascular access. We are the only device in the market that is able to do biplane imaging, since we can scan 2D at the same time. That shows you both short axis and long axis for anesthesia and for different applications like cardiologists. We have also introduced our gestational age AI that with few sweeps you can identify the gestational age. There is a lot more into this direction, but what really makes us proud is the ability to pack our application with educational material on demand. So as you navigate through the preset, every preset you select, an on-demand video will pop up between few seconds to few minutes to allow you to start quick, right? And these videos, around about 290 videos, takes you from zero ultrasound the whole way to advanced, and it teaches both acquisition and interpretation. Should I stop here? Okay.
Thank you very much. Our next speaker is Dr. Mudoni Ntonjira. I think she'd probably want to be known as a doctor. She's an anesthesiologist. She's done an MBA in healthcare management. And right now she's the managing director for Philips East Africa. So maybe I can give her also some 3 minutes to talk about what Philips is doing in terms of point of care ultrasound and what devices they have.
Thank you so much, Dr. Ganda, and it is a pleasure that we finally met. Thank you again for the organizers of this platform. I think this is a much needed topic to address. I won't go into the details of the product, but what I want to mention as a very brief overview is we do have a point of care ultrasound known as the Philips Lumify. The Philips Lumify is a product that has been in the market for quite a number of years. And is available in Africa, in Kenya. Lots of consumers of the solution who are currently using it, and has been deployed in different levels. So it has been used both at a primary healthcare level and even at a tertiary level because of the diverse functionality that it has. So the Philips Lumify comes with 3 probes, and what we have is a curvilinear probe, which is what you use in obstetrics. You have the linear probe that is mostly used for vascular and peripheral vascular access and regional anesthesia when it comes to anesthesiologists. And of course, we have the cardiac probe. And one of the unique features about the Philips Lumify is that it's a tool that can be used for any device, both Android and iOS systems. We've also used it in different levels of care. Of course, with diverse indications, both cardiac at a primary healthcare level. We're currently, I see Doc here smiling because I'm about to talk about Mimba Afya. But before I get to Mimba Afya, I want to speak about the current study we're doing with one of our professors here. And we're trying to implement combining ECG and the cardiac probe for the Lumify in identifying patients at the primary level at triage who actually have features of acute coronary syndromes, those who present with any chest pain as one of the indications. So another bit that we have used when it comes to studies is, of course, we've run a very extensive project with the Aga Khan University Hospital in the Mimba Afya project in rural Kenya. We were running this in Kilifi, and what we're trying to do is educate and train midwives to be able to do the basic obstetric ultrasound, more of a screening ultrasound, to be able to identify whether there are any risk factors that are identified when a mother is presenting at the first point of contact during the antenatal clinic. And then at this point, the midwife, who's the practitioner at this point, is able to conduct the ultrasound, identify any risk factors, and also able to, identify features like, is it a singular pregnancy? Is it multiple gestation? Is there a heart rate? What is the presentation? And are there any risk factors like, placenta abruptio or placenta previa that will require a referral for the mother? Another bit that's really important, I know you want me to stop, but before I stop, I want to mention this. We currently have a running program or project, and this is a project where we are funded by the Bill and Melinda Gates Foundation, and we want to embed AI protocols into the ultrasound device to be able then to allow task shifting. So you have other healthcare givers, like the midwives, able to do the basic ultrasound, guided by, and can make decisions based on the clinical decision support tools that are embedded within the Lumify ultrasound. And finally, before I leave, one of the very important elements when we're looking at some of the challenges we face in our African context is always the human resource element. Yeah, so last bit. So for telehealth, we have an application embedded called React. This is currently embedded in our Lumify, and React is an application that helps you as the primary practitioner who's doing the ultrasound to be able to have real-time guidance by either a senior, whether it's a radiologist or an obstetrician, who in real time can do the ultrasound and give you guidance as you use the tool. So this is a very important element when it comes to telehealth. Sorry, I just had to say that. Thank you.
Thank you very much. Thank you. And next we'll have Alexander Okech, who was named as one of the top 40 under 40 people in 2022, and is a transformational leader, but works for GE. So here we'll call him GE. Maybe you can tell us something about GE in this space.
Thank you, Dr. So Alex Okech is my name. Currently the Regional Projects Development Director for GE Healthcare in Eastern Africa. I have a video for 20 seconds. I want to seek your indulgence to play it. Thank you. called the Viscanair, as we just seen on the screen. So we have different categories of this ultrasound. The Viscan Air specifically is for triage services, so it's a triage ultrasound. Then we have a Vasana Active, which is an antenatal ultrasound. And then we also have a V100 monitor, which is a vital sign. Now, all these systems are affordable. They fall within the affordable technology. They are AI-powered and WHO compliant. Now, in terms of functionality, we focus more on the clinical stage, then we move into the primary care, and the work mainly is to support, reduce infant mortality in terms of providing the appropriate solution for our radiologists and gyna and OBS within the medical setup. Stop it there.
Thank you very much. I think they can still hear me. And finally, at least I know your technology. I may start speaking before I read it. As H. Potter. I don't have your. Maybe you can introduce yourself. Allow me to allow you to introduce yourself and give us 3 minutes about your technology.
With your kind indulgence, if I could use the 3 minutes with my slide, should it be okay? Yes. Slide. PPT. Yes, as the slide comes up, my name is Erickson Band. As I mentioned earlier, we represent Delft Imaging. Delft Imaging, as you know, is a diagnostic equipment manufacturer who are trying to come up with solutions for diagnosis in very challenging surroundings. And as it's going to come up shortly, we are known mainly because of digital X-ray. Digital X-ray. We have a global impact in 65 countries. If you've heard about CAD for TB software, where we are in 50 countries and we've tested over 14 million people. In Kenya, currently, we have 8 sites in 8 counties where we have a chest X-ray that is portable. And once you get the X-ray image, you download into a CAD for TB in 5 seconds. You're able to diagnose whether the patient has TB, and if he has TB, then you make it you refer the patient for further tests and further management. Now, using that knowledge, already this is about us in digital X-ray. In the artificial intelligence for safer pregnancy, our main focus is primary health care, where we would want to empower the primary health care providers with ability to be able to detect risky pregnancies and make timely referrals. Dr. Serem already mentioned that slide, so we're going to skip about it. You also mentioned about the ultrasound capability, where we have 6.9% women having access to ultrasound in rural areas in sub-Saharan Africa. We'll skip about that in the interest of time. In the interest of time, we know that there is lack of resources. Like in Ghana, we have a typical case of a lady saying an ultrasound device is only available in the district hospital, 2 hours by bus. We've already had that conversation. But in our health clinic, if we want to make a real difference, we need accurate diagnostic tools that are easy to operate so we can refer to pregnant women in time to the nearest district. That is the case in Ghana. If we can now skip so that we can be able just to speak to what we are saying, as Dr. Ari was saying, we are trying to empower healthcare workers in primary healthcare to make pregnancy safer. So if we can move on in the interest of time. So what is baby checker? Our ultrasound, our POC is Our POCUS is about an artificial intelligence to assess ultrasound images and detect risky pregnancies to improve timely referrals from primary healthcare facilities. So at the primary healthcare facilities, the patient, the pregnant mother who is presenting there will have a sweep of 6 protocols, and that will take 2 minutes to do those sweeps, that protocol. And from there, we are able to identify risky factors of gestational age, fetal presentation, multiple pregnancies, the number of fetuses, placenta localization, and fetal heartbeat. And what's going to happen is that on the smart-based phone of ultrasound, it's going to display a traffic light. If in case or any of those risk factors are present, it's going to present, and the primary health worker is going to refer the mother for further management. In what is our value proposition? Maximum 1 hour training, and we're good to go. And then it functions offline, no prior experience that is required, and there's no cost of power that is required. I can already see Dr. is standing, so let me stop at that.
If I give you time, all of you can talk about ultrasound for an hour, so I have to cut down. But thank you very much. Maybe you can give them a round of applause. Now we know them and what they do. So these are actually the largest companies that we know that are in this space of point-of-care ultrasound. And I've given them a pen because I want to ask them several questions at the same time so that they answer. And so all of you have been involved somewhere in Africa. Many of you in Kenya. I think only one has not been involved in Kenya, but somewhere in Africa. What challenges have you faced when deploying this technology in Kenya or in Africa, in terms of training, deployment, scale-up, training of cadres? And then secondly, what advice or recommendations would you give us to enhance the adaptation and utilization of POCUS? So I've given you 2 questions: challenges and the recommendations that you would give us for us to be able to adopt and utilize POCUS. And again, I'm going to give you 3 minutes because we've consumed almost 20 minutes and we need 15 minutes for discussions. So 3 minutes each. Just highlight the challenges that you faced and all that, and then what advice you have for us. And then I will give you a chance, the people in the panel, to answer questions from the audience. So maybe I can start from, who is ready?
Thank you very much, Dr. Ganda. That's a very relevant question. Of course, I'll start with the challenges, because challenges lead to opportunities. One of the greater challenge that we have seen is, of course, when it comes to human resource and the level of training that is needed in such setups. There's a lot of support when it comes to the county or the national government or whoever is investing in the solution that is to be provided within the healthcare facility. But one of the bigger challenges that we have faced is who is the resource? Do you have a sonographer? Do you have a trained midwife who will be able to carry out the screening or who will do the imaging procedure themselves? And of course, human resources for health is a global concern when it comes to, and I saw that of course was a topic earlier today. But what we have done and to mitigate this challenge, and I like the fact that Dr. Neith is here because she did some amazing work as a principal investigator together with Prof. Marlin in looking at how do we, in the context that we are in Kenya, how do we deploy our innovation so that we tailor-make it to meet the needs of the local context. One of the best things that I appreciate about Philips is that we are not developing solutions that are one-size-fits-all. We're looking at the demographics that we're working with. We're looking at the health ecosystem in the region where we want to deploy our solution. And for that reason, then, we have a lot of support from the Philips Foundation, from Philips itself, in conducting a lot of research locally so that we have results and data that is representative of the demographic where we want to deploy our solution. So we have been able then to, and that's what I was speaking to earlier, look at how do we make this solution as user-friendly as possible, ensure that the hands it falls on at the primary healthcare level is actually able, or the practitioner who is using the device is able to use it to the best, optimize it and use it appropriately, and is able then to improve the patient outcome most efficiently. In addition, we do not, we look at the fact that there are other practitioners within the healthcare space that are caring for patients at different levels. And so we'll seek inputs also from the physicians, the obstetricians in this case, for this particular context, and also seek guidance on how do we integrate a solution that the primary practitioner who's at the primary healthcare level can conduct the ultrasound, but then if they're stuck or if there are any challenges, then they can get guidance. And that's why I mentioned we have that React solution where you can have the primary practitioner get guidance from a more qualified, say a radiologist or an obstetrician in making a diagnosis. So that's one challenge and a way of mitigating it that we have found as a company to be able to deploy our solutions within our context. Secondly, one of the bigger concerns that we face is, of course, but we have found a way to mitigate it, is training. We know that there's always a turnover of staff within the healthcare facility. So you will train the sonographer who's initially working within that department, and then you find that he's been moved elsewhere, right? Or the midwife has been moved now to work in accidents and emergency, right? So when it comes to training, training has to be continuous. It can't be only at the point of deploying the solution or at the point of purchase of the equipment by the hospital. It's a continuous process. As you know, the kind of setup we have in our countries, you'll never have any healthcare worker who's been in a department for 10 years without any rotation. There's always a rotation that they go through. So for us, training is a very key element. So being in a constant communication with the healthcare provider, being in constant communication with the healthcare facility to understand what their training needs are. The other bit is we are trying to move away from healthcare institutions looking at us, and of course, I hope I'm also mentioning something my colleagues here will look at. We don't want to be looked at as vendors. We want to be looked at as partners. So we come to you and get to understand what your need is and move away from a transactional relationship. And that's why I'm very happy about this kind of forum we're having, because then we get the feedback from the healthcare givers, from the stakeholders in the industry, and then take that feedback and see how we can implement it in driving and having the right solution out there in the market. Because at the end of the day, we are all looking at achieving the quadruple aim of care, improving patient experience, improving staff experience, lowering the cost of care, and most importantly, the center of it all is a patient, and so having the right patient outcomes.
Thank you. You can pass it on to Alexander. Thank you very much.
Yeah.
Alexander, you don't need to talk what she's talked about because it's all one panel. All of it is about point of care ultrasound. So are there any other challenges that you think exist?
Yeah, so just to maybe amplify, our approach as G is contribution to preventive unnecessary mortality. Now, we focus on a wing-to-wing solution. We don't only look at the point of care ultrasound, but we look at the entire ecosystem to make it work. Now, I mentioned it's affordable. So one of the challenges we have is capacity building within the healthcare environment. So how are we dealing with that? So in G, we have what we call a tax shifting program, whereby we train the midwives and the healthcare workers in respective healthcare environment to be able to use our system seamlessly. And that takes time, but that doesn't take time, it takes a short period of time. And then we have a trainers program, so that then the solution is used within a bigger portfolio within the primary care. Now, in terms of recommendations, part of the recommendation for us is offering continuum care. within the point of care ultrasound. And how do you do this? We ensure our technology are user-friendly and they are also portable. Like for us, it's a portable solution, meaning you can carry it around. And we have many successful stories we have done in Ghana, for example, where we have already deployed over 500 Viscan, which are portable ultrasound. In Ethiopia, we have partnered with AMREF and also USAID to train up to 200 healthcare workers. These are a range of midwives and other cadres within the healthcare. So we have deployed that in Africa. In Kenya, we have just signed an MOU with Kenya Medical Training College to be able to deploy that solution. And our focus will be the task shift program. Thank you.
Thank you. Can you hand it over?
Thank you. The first challenge is about what the conversation that we had in the morning, the lack of guideline and policy. And the second challenge is about acceptability among the stakeholders. The solution needs to be acceptable. The other challenge is about ethics and standards, because, for example, I have this probe and I have a primary healthcare worker who is actually seeing the images of the fetus on the smartphone. What's going through her mind, and she does not have the right kind of training. A lot can go wrong, and it can lead to a very how to put it, a very innovative healthcare worker going beyond what she's expected to do. And then there is need to define what is actually screening, and that's where the positioning, where the challenge, where our offering is, and between POCUS. And then can this probe work without AI? It requires AI. So in terms of recommendations, we recommend definition between screening and point of care. It's a thin line. Of course, we recommend it requires training, and the more less training, the better, because as it's been proven is that at initiation you'll train someone to 99%, and somewhere along the line, the kind of knowledge retention goes down to 66, and that's risking. And then there's with AI, there needs to be validation. We have so many AI solutions. We need a solution when it's actually saying that there's a risky factor. Indeed, there's a risky factor, and we don't want a solution which is there's a risky factor and it fails to detect. So those are the challenges.
All right, fine, thank you. And finally, my colleague from Butterfly. Any challenges in Africa?
I don't want to repeat the same, but one of the things that we identified as a challenge is lack of standard, where different hospitals, different states, everyone follows specific guidelines. But that not necessarily means that everyone does the same thing, right? And so there should be a framework, and a technology provider should provide this framework to enable the end user to have a standardized way of procedures to follow this, so to ensure safety, quality, and access to everyone. So I think that's one of the major challenges.
All right, fine. Thank you. Thank you very much for those responses. I'm just going to go back. Just one question for Dr. There is the issue of partnerships versus wanting to be seen as a partner versus a vendor. But I'm asking because these innovations have to be paid for. How do you get paid when you consider yourself a vendor vis-a-vis a partner and not a vendor? And what have you ever gotten paid by any government agency using this method of partnership and not being seen as a vendor? And I think that's a question which goes across even to the other people. The second question is, you talked about affordability. What does affordability mean to you? Does it mean that the government can afford, or the woman, because you're talking about obstetrics, down there can afford? And do we have statistics that out of 50 who needed scan, maybe 20 were able to afford the 500 or 1,000 that you are charging? That is not yours. Yours was the first one, though.
Mine is the first one. Okay, thanks for that. So when it comes to the reason we talk about partnership is because we will be with our partner, whether it's the government, county or national, or whether it's a healthcare institution, from the moment they're looking at their strategy. The strategy being, what do they want to invest in for a particular financial year? Look at what the needs are that they want to address. Of course, we have a range of solutions that you want to offer. So we're not coming in at only the point of procurement, but we'll sit down and with many institutions and look at what the strategy is for that hospital. Are you looking at expanding from having maybe a hub and scope model where your hub is centrally located, and then you have your spoke as many satellite clinics that feed into that? So what solutions would fit into the tertiary hospitals? What would fit into the satellite clinics? So this is more of an advisory role, yeah? And if we're looking at ourselves as a vendor, then we're coming in only at the point of procurement. And that's not the kind of relationship we want to have with any of the healthcare partners or stakeholders in the markets that we operate in. Secondly, we are also not just a commercial entity, but we're heavily invested in research. And we do research through different arms of Philips. So as much as, yes, we do have Philips, the commercial entity, but we also have the foundation, Philips Foundation. And the mandate of Philips Foundation is to help us as Philips to achieve our very ambitious goal of improving 2.5 billion lives by 2030, and 400 million lives per year are in underserved communities. How can we be able to reach underserved communities? We must work together with other development partners, whether it's government or non-state actors, to be able to ensure that there's access to care to some of the solutions that we have. And through this arm of the foundation, we've been able to work with social entrepreneurs. We've been able to work with governments. We've been able to work with research arms of different organizations to develop solutions that also feed into providing access to care, and at the end of the day, also ensuring that we are improving lives, particularly in those underserved communities.
Okay, but have you ever gotten paid by government?
Yes, we have.
Okay. Kenya government?
Kenya government,
so
yes.
How, go back to the next question about
Let me just
affordability.
add, the government is a very good customer.
Yes, go ahead. Go to the next. Why I'm asking this question is because the government has a problem with pay per use. Government knows how to buy. How much is this? Buy, bang, it is finished. But what you're talking about is a pay per use. So you have to pay for a number of users, and that fits very difficult, usually, the procurement system. That's why I'm asking, how did you go about it? And that is a big problem for a lot of innovations where you are doing service as a software to penetrate the market in Kenya. But I'm happy you are paid. Maybe you will share with us how they paid you. Yes, my colleague.
So from a affordability standpoint, our reference here is the cost of ownership and the affordability to own the technology. So when we are designing this solution, we ensure that they are affordable from a cost standpoint, that the hospital or the radiologist or the obstetric gyno can afford that solution. And we make it in a way that it's flexible. We also have financing solutions, meaning we can have a discussion with the purchaser here and see what options we can explore to enable it's accessible and is affordable. And then lastly, on the training, we collaborate with clinical societies in countries where we operate to ensure we support with training. And the training here is taking away that training from mainly OBS to midwife and healthcare workers, so that then it becomes easier and the using also of the system becomes flexible.
Okay, I'm going to cut that short a little bit. I'll give you time to talk just after this. I want to open it up for questions so that you'll answer your questions together with the questions from the panel. Do you have any questions, concerns that you want to ask the panelists? Or can I continue asking my own questions? Go ahead.
Thank you, and thank you for your presentations. A couple of questions. One is data security. Where is this data getting stored? Who owns it? Who can monetize it? Who can leverage it? Two is medical legal. With AI, and I think that issue arose, just who takes this responsibility if things go wrong? Is it your AI solution, or is it me as a hospital owner? The third is upgradability. How live is your solution? When you upgrade software, because I know the hardware is fixed, but software upgrades can make a tool much more useful over a long time. So how are upgrades handled? And finally, and this is a broader question, all these tools that are coming, how are we going to regulate their entry so that we do not get junk into a market? Because the PPB is the one I think that's registering, and most of them are pharmacists. I am not quite sure how they are coping and how we can help them cope with solutions that are as far from pharmacy. They belong in the field of mechatronic and electronic and software engineering. Thank you.
Very nice questions. Any other?
Thank you. I'll actually had similar questions, but I'll just try and give my own. I had two. One was about the maintenance. I mean, these are different devices. So, I mean, post sales or purchase of these devices, like what support do we get in terms, because, I mean, maintenance is required. Secondly, I'm sure there are newer generation devices that will come in the future. So what happens with the old ones that we have? Second, talking of the AI. Now, these are different devices that we have heard of. So about the standardization of the AI models that will be there. I mean, if I'm going to be using Philips or I'm going to be using Butterfly, will there be standardization on the AI models, or these are different models and giving me different responses, I mean, when I'm doing the scans? Thank you.
I think we're now waking up. Two more questions and then.
Thank you. My name is Jeffers Kenyanya, representing the Society of Radiography in Kenya, and where sonographers fall under us. The discussions here are good, and what we need to do is to ensure that the primary users or the primary professionals who are the radiographers and radiologists are extremely involved into these discussions, and their advice or their opinions taken into consideration very seriously. On the issue of training, now that vendors are talked about their involvement on trainings, our experience largely has been that the trainings you undertake are more biased into application training, application, how to use the equipment, the hardware. And the trainings here that we need to be discussing about is trainings that are pathology-oriented, anatomy and physiology. So we cannot sit here to reason or being talked to about trainings, and when those trainings are more of the mechanical aspects of the equipment, to maneuver the equipment and all that. And those trainings are never standardized, because if you looked at one vendor, the application training will be different from the other vendor. So we need to see how we can bring on board professionals into those trainings. And that's why the discussion in the morning has been, do we have policy? The policy that then will guide us on curriculum development. We standardize the curriculum, and then we know who qualifies to train, how long, and who, what are the entry requirements to train us at that point of care and staff. Thank you.
Be very brief with your questions. You only have 5 minutes.
Thank you so much. Mine is just a quick one, and I may be preaching to the choir, but you know that ultrasound machine, the pricey part is the probe. Do you have warranties for probes? Because the machines that you're all talking about, the probe is something that someone can put in the pocket, and you want to put these things in the primary healthcare centers. And I don't know about the security. These are not things that can be, I don't know, that needs to be discussed. But do you have warranty when I buy and the probe is lost that you can replace?
Thank you so much. Mine is on how far can this machine, all the limitations. When we talk of POCUS, we are looking at a specific area. So, and even when you're using AI, how far can AI go? Or maybe if you're doing an OBS in POCUS, how far is that midwife allowed to probably do that? And who also owns that? That's on policy, but how far? How limited is the machine?
Thank you. We're going to start answering from that side, and then you, and then the last two. Go ahead.
Thank you. I'll start with the question of training, and I agree with Daktari there. We as OEMs cannot come and purport that we want to train the primary health workers as sonographers or radiographers. What we are doing is that we're coming with a probe which has all that capabilities, and we're giving the primary health worker the tutorial that enables him or her to know how to be able to take the scans. And that's the reason, as far as our solution is concerned, when in the 6-sweep protocol, when she or he is doing the sweeps, she is not able to see the image. The image comes later when the scan is downloaded now into the AI. Note that our probe cannot show the image. We just find the medical legal, area of standards not to be very clean to allow this healthcare worker who has not been trained far enough to be able to go that far. But you will be able now to see the image at the end, and immediately the 2 minutes are over, the scan will drop into the AI solution, and 2 seconds the AI will be able to tell the 5 risky factors and give a green light that the mother should go, or give a red light that the mother should be able to be referred because of 1 or 2 issues. That brings in now the question of affordability. Our solution is very affordable because, one, we ourselves, the primary thing here is the AI. And our AI, to answer Doc there, is the validation of AI by WHO assures you that this AI has been used in different countries under different conditions, and it's been able to provide different results, the same results. If then there's going to be any publication that shows that this AI has not performed as it's supposed to be, then that will be able to be the backstops on the AI provider. For us, we pride that for many years, we are the first card for TB, and it is proven and validated. The most validated AI in the world is our AI. About upgrade, it's upgradable. And just to speak a little bit on the cost affordability, because you have this at the primary healthcare, at the level 1, level 2, you are now ensuring that this mother is enticed, first of all, to come for the ultrasound. And then secondly, does not need to travel so far to be able to unless she has a risk factor. And you are assured that with AI capability, this primary health worker is able to give a solution that the sonographer or radiographer will be able to screen. So the person who is being referred to now for expert treatment, there's a lot of savings there. And in our case, we give a perpetual license where we'll get upgrades, or you can opt for an annual license with a minimum of 1,500 or 1,500 scans, whichever you can go for. I'll leave the other questions to be handled by the panelists.
All right, fine. Go ahead. Please. Sure. By the way, you don't have to talk about, you can also just talk about the point of care ultrasound in general, because these are challenges.
Just go through the questions that was asked. So one question was around data privacy. So any technology has to obey, international standards of data privacy. And the way we do it, basically, regardless if we host this data that you've captured with our devices in your prem, on your prem, or on the cloud, it has to be encrypted end to end, right? We do not have access to what kind of information between generation of data to storage of data, right? Only the user have access to this. The other question was, and this is a big question, I'm hearing this a lot, about AI. So my perception about AI, and I've worked in AI for the past 5 years, AI is just an assistant tool. It will do what you train it to do, no more, no less, right? To build an AI, you need an immense amount of data that is structured, cleaned, and trained. And it has to be done by specialists. So the data has to be annotated by qualified radiologists or physicians. So now, when this model comes out, it proves what you just trained it to do, right? However, we can't leave the responsibility on the machine. Someone sitting behind the machine doing random pickup, doing peer review, and deciding every now and then if this machine is doing what it's meant to do, or is it failing, right? So it's back to the human decision. So AI is there to assist us. AI will, and I quote one of the professors in one of the conference, clinicians who use AI will be better clinicians than those who don't. And that's it. So we don't have to fear so much about AI and what is the use. There are regulations already in place, can be used as a guideline on that space. In terms of maintenance, cost of maintenance, so of course every machine comes with a standard warranty, but you can also extend the warranty as you wish. What we appreciate so much about Butterfly is that our device does not require maintenance, does not require calibration. Since we don't work with piezoelectric crystals, which is technology that has been there for 60 years, we use chip technology. It makes us less maintenance required. If the device fails to perform within the warranty, we replace it with a new probe. That's how we operate. Question was around what if the probe was lost? I think you asked this question. That's a very good question. So in our ecosystem at Butterfly, we have made it possible to lock any lost device. So if your device disappeared, the person who gets hold on this will not be able to use it because it is locked. So we have a fleet management functionality. And I don't think it's only Butterfly is capable of doing this, but I'm just speaking about Butterfly now. It is possible today to monitor where the device is and track it and lock it, if you will. Involvement of radiographers in training, I guess this is a very good question. I think one of the philosophy that Butterfly is aiming at is basically introduce point-of-care ultrasound at medical schools and at nursing schools. We want people from year one to use ultrasound. We don't want them to wait until they graduate and to be intimidated by learning ultrasound. And so when we do trainings, we do have in our portal, in our platform, and this is all within the application of Butterfly, you do have access to learning anatomy, learning physiology, interpretation. This is there. This is on demand. But we also have the Butterfly Academy, where you can have a didactic course, can go through the entire course, whether it is physics, anatomy, or pathology, under one umbrella, and you can get certified. But this is all Butterfly-made courses.
Okay, thank you. I think you've answered most of the questions that were asked. We've run out of time, so I'll only allow you 10 seconds to say one last thing, something that you think they didn't say about point-of-care ultrasound.
Yeah.
And you 10 seconds. Please,
Okay.
10 seconds.
10 seconds,
Yes.
absolutely. One topic that's very important, it was also a question, is regarding what happens to the old devices. So one of the things I want to mention around sustainability is that is one of our primary focus as Philips. So when it comes to old devices, we actually have what we call the circular economy. So we take up old devices, either we upgrade them, because all our software is upgradable, or secondly, we have a buyback solution, take the older system that's not in use and replace it with a new system with a buyback or trading option that we give our customers.
Thank you.
10 seconds. So there was a question on warranty. And the question on regulatory. So we are FDA compliant, being an American company. We'll never bring any junk to any country. We're also ethical. Two, the issue of warranty. So all our systems come with a 3-year warranty, upon which we upgrade at no cost. Plus, we have no subscription fee for all our systems. Thank
you. Thank you very much, and thank you very much, everyone. A round of applause for them. I would have given you a second to say something last, but I think we've run out of time. Asante, and over back to you, Dr. Lai.
Thank you very much, everyone. So, as we are moving, I think you can see that the conversation is advancing. The technologies are here. If someone wanted to use them, you can pretty much start using them tomorrow. But how do we pay for them? And I think that's the next session that my colleague is going to lead. Dr. Matiko Riro is a health financing expert, and he has a smart team of health financing people that are going to help us figure out how we pay for these things that we've been talking about since morning. Matiko, over to you.
Good. Thanks, Dr. Lai. I know the bigger question that kept on coming up this morning was, how will it be paid for? And one institution kept on being mentioned every now and again, and everyone was looking for them. Where are they? Where are they? So I'd like to invite a couple of people that are interesting to talk to. We'll try as much as possible to squeeze this within the next 30, maybe max 40 minutes, so that we end as early as possible. So I wish to welcome Dr. Gakombe, who is the chair of Kenya Healthcare Federation. I think Dr. Gakombe introduced himself this morning, but for those who do not know Dr. Gakombe, he also happened to be running one of the most successful hospitals or healthcare providers in this city at Metropolitan Hospital. Dr. Gakombe, please, welcome to the front seat. The next person that I'll wish to welcome is Julia Ouko. Julia Ouko is probably not new to us for those who have interacted with NHIF. Julia heads the benefits department and provider contracting, so it will be interesting to talk about all the many questions that we had this morning around how does this come up. Julia, please welcome to the podium. The next person is Dr. Maggie Mwoka. Dr. Maggie Mwoka is, is a program manager for diagnostics at Clinton Health Access Initiative. He's been leading quite a lot of other initiatives across a private provider, that's public-private collaboration. So it will be interesting also to get to understand how that works. And finally, I wish to get someone from COG, that's Robert Rapando, who is a health system strengthening and policy advocacy strategy specialist, and is here with us today to maybe give us some bit of wisdom, especially from COG and some of the aspects that we can talk about. So, thanks everyone who's here, and please, as they talk, please keep your questions, because they are, after all is said and done, we need to now think about that, yes, the patients are there. Do we need them to pay out of pocket? One of the things that we want as much as possible, especially as we work towards UHC, is to reduce out of pocket as much as possible. So we create systems, whether prepaid or through government systems, that enables them to access care, not due to their or because of their ability to pay, but to us and when they need it. So I'll wish to start off with Julia. So Julia, this morning, there were a lot of fingers pointed to one institution, which happened to be probably the oldest national health insurance in Africa, having been established, I think, now 60 years ago. So one thing that came a couple of years ago was something, a lot of people don't talk about it, but Linda Mama is essentially one of those interventions that has gone a long way, or at least as envisioned, in terms of trying to alleviate maternal mortality, or at the very least, trying to break the barrier of access, more so financial access. So Julia, are there opportunities there to scale POCUS, but more specifically around how can we get into the benefit package? Are there opportunities to get into the benefit package? If there are opportunities, what modalities can we get, especially around all these conversations we've had, who handles it, where, how many times can we have it in the course of the pregnancy, and all that. So it will be interesting to hear that from you. Over to you, Julia.
Thank you, Dr. Matiko. And once again, thank you for the opportunity. Good evening or good afternoon, everyone. I would not know where to start. I don't know how many minutes I have.
5 minutes.
5 minutes. Great. The year was 2016 when the government program-led free maternity was transitioned to the National Hospital Insurance Fund then. Currently, we are National Health Insurance Fund. Will soon be gone, dead and buried, to be Social Health Insurance Authority. So when it came in 2016, we branded it. We gave it a name and we called it Linda Mama. Linda Mama is Swahili for take care of the mother. Though when we walk around the country, they call it Mama Linda. So we don't know who Linda is. So when it came, by then we were covering ultrasound. I'll be specific to the topic of the day. We had just renewed our contracts. NHIF contracts healthcare providers for a cycle of 3 years. So we had just started the 2018 cycle, and we were paying for ultrasounds. But what we saw in 1 year, we couldn't continue. There was a proliferation of claims for ultrasound because we were paying it as a package at 3,000 Kenya shillings. And we did our simulations, we looked at the data, we did the projections, we said, no, we are going to close this organization. We do not collect money for ultrasound only. So the payments were rocketing. And what the board agreed that we need to do is to incorporate ultrasound in the outpatient care. So, you know, as we finance outpatient at NHIF, we finance it through a system called capitation. So as I sit here, ultrasound exists at NHIF, but under capitation. So if this room was full of healthcare providers, I would ask them, raise your right hand if indeed you are taking care of our patients, of our members, by offering ultrasound through capitation. They don't. So what is the problem? In comes Linda Mama. Linda Mama, we can only give what the government has prescribed. The government gives us 4.098 billion every year to finance Linda Mama. And the payments are 100%. When the funds are over, we tell them it is over, we are waiting for you. The utilization is 100%. And the figures are there. So like last financial year, we had a registration of 954,000 members or Kenyans who accessed Linda Mama, and all that was paid for. So if I'm going to pay ultrasound for 954,000 women, are you giving me the money, Matiko? So yes, we can include it in the outpatient, we can include it in the antenatal visit, which we finance at 500. So are you willing to have it there and not bother us?
Good. Thank you. So as you hand over the mic to Dr. Gakombe, yeah, and I'm sure the team is really raring to ask you more questions, especially around, the bits and pieces. So I'll not even bother to ask you more questions because I know the team is preparing more questions. So maybe to Dr. Gakombe, I know, especially the private sector, so you happen to sit on the other side, especially around how do we shape. I think Kenya, arguably, we have 50-50 in terms of the share of service provision. And also there's a role that the private financing side actually plays. So if you look at the insurers, right now I think with private insurers, we have about 20 of them that provide financing for care. Do you see, and I think there's been a lot of other conversations around pre-authorizations and a couple of others. What do you see a role or do you see opportunities that private insurers can have in financing, point of care ultrasound, especially as we talk about task shifting or task sharing? Do you see them adopting this, or they still be stuck to, no, this has to be done by a radiologist, this has to be an ultrasonographer? So do you see an opportunity of engaging to give us such opportunities? Over to you, Dr. Gakombe.
Thank you. We're having a number of shifts in the industry, and it's important that we all are conscious of those changes because they'll mean a lot. One of them is the reforms in healthcare financing. And part of what those reforms mean is that we've shifted from contracting to providers. At the moment, NHIF really doesn't care who I contract. They expect me to provide a comprehensive service, and therefore paneling of specialists is left primarily to providers. Secondly, we are increasingly moving into the AI space, not just in medical technology, but in claims processing and payment solutions. And this offers an opportunity to solve one of the problems NHIF faced, which is fraud, waste, and abuse. Because if we are going to pay for services, we must do two things. We must increase the amount of money available for healthcare, and we must keep away those who want to take money that they have not rightfully earned by making fake claims to NHIF. And AI offers us a great opportunity to do peer benchmarking, to detect those who are doing things the wrong way. Thirdly, we have an opportunity in terms of scaling up insurance, because medical insurance is now a mandate, and not only does that mean more money to social health insurance, it means citizens are for the first time paying attention to the fact that healthcare is expensive and we have to pay for it. Because if you remember from independence, the political narrative was that healthcare is free. And nobody plans for free things. None of us here has a budget for air. We are talking about climate change, but none of us here has a budget for air unless you run a hospital facility, because air is free. So one of the biggest changes is that we are saying healthcare is expensive, so we have to pool resources and pay for it. To come specifically to private insurance, for a long time, pregnancy wasn't covered. Now many of the insurers are covering wellness, generally, and many of them are including cover for maternity care. So there is an opportunity, and we as providers are the ones who will determine which technology we are going to use, much more than NHIF or any of the insurers being prescriptive about which cadre of healthcare professional or which technology that we deploy, because they hold us accountable. So I see a great opportunity. Many of us will move this way. And one of the questions I actually asked myself today is, so what happens to my 3 large ultrasound machines if GE and Philips and Butterfly are making pocket-sized devices? It's a conversation I intend to have with them before we leave here. But I see an opportunity. Okay. What we'll need are, and we need you as healthcare economists, to make sure that reimbursements are actually economic, so that we are not skipping important things like not doing ultrasound at all, because every extra thing we do means an extra cost to the cost of care. Thank you.
Absolutely. And I think, so one of the things you've mentioned, and it will be interesting to hear from maybe at some point when you have the personal conversations with Philips, GE, Butterfly, and Baby Checker, is, there are over, I think Dr. Serem mentioned this morning, there are 1.5 million pregnancies in Kenya every year. And if you look at 1.5 million, and then you're having probably a couple of machines across the country, so we arguably probably have about, maybe 5% accessing the bigger machines. So if we can get a pipeline of people getting to the bigger machines, that would be a fair one, no? Yeah, so it's around thinking around all this. How can we make it happen in the process? So thanks, Dr. Gakombe. So I'll wish to move swiftly to Dr. Megi. So Megi, you've been leading, pieces of work, especially around private-public collaboration, especially around labs. So how do we get the private sector play a role in terms of improving access to lab? Because one of the elements that probably those of you who have worked in public facilities, once I'm seen by a doctor, in most cases, if you are in Eldama Ravine where I was for 2 years, you'll be given a list of tests that you'll go to a lab outside there. So, and that's constant across a number of facilities across the country. So one of the pieces of work that Megi has been doing with a number of counties, I think, in Tharaka Nithi, is trying to see how can we get private providers actually, without having to raise costs or prices, actually just ensure availability of services and, work on things like stocking, downtimes and a couple of others. But it will be interesting to think about that in the lines of diagnostics, especially looking at POCUS. What are the opportunities and what are some of the suggestions that you have? And happy to hear what the team has a response around that as well. Over to you, Maggie.
Thanks, Dr. Matiko. So he didn't mention that he's my boss technically, but so what we've been doing as CHAI, as Dr. Matiko mentioned, is really trying to demystify the idea of how counties can work with private partners and trying to demonstrate and showcase that there are different models which can actually be used with the purpose really of improving access to quality and affordable services for citizens within the counties. And when we talk about public-private collaborations, I think of it two ways. So you could have ones where you have capital investment, and you could have ones where there's no capital investment. And by that I mean where there's no capital investment, a typical public-private collaboration would be, for example, policy dialogues and information exchange. Essentially what we're doing now, with the purpose of, can we be able to start creating an environment whereby I think the Philips, it's Dr. Mudhoni had mentioned, instead of being vendors, you're partners. So can we start creating such kinds of environments where we're aligning and enabling each other to work? Then on the other hand, you have your capital investments. And unfortunately, in most cases, what we've seen in the work is that when you think about PPPs, it's infrastructure. That's the first thing that comes to mind. It's building a hospital and so on. But then we started thinking, okay, there must be a way whereby we can also bring in and leverage the private partnerships to be able to improve access to services. And so one of the key models that we've been able to sort of look into is, how about a purchasing agreement model or an outsourcing model, which is not new. It's happening in other countries very well. And it's really looking at how can perhaps a county government, for example, be able to contract out a private partner to deliver a particular set of services within a period of time, and the cost to the patient remains the cost that the county government will set, because again, the key thing here we want is affordability is maintained for the patient. And largely what we see is that when we've been able to sort of conduct feasibility studies, and now this is in the lab, just bringing in learnings from the lab sector, the diagnostic sector, is what we see is county governments have the volumes. The demand is there. The number of people who go through those hospitals are there. So we said we have 6.9% who are accessing. We have 1.5 million births right now in Kenya. How many of those women are accessing those ultrasounds, for example? Math? 25%, correct? That means we have a gap of 75%. So the demand is there, just within our public hospitals. The demand is there. So the numbers are there. Then the question comes in, okay, we know we have the numbers. We know as government, in most cases, we might not have the full capability, especially when it comes to financing. So then the question is, one, in terms of financing, two, in terms of efficiencies. The challenges are around, okay, we've all mentioned here, it's challenges of staffing, it's challenges of reagents, supplies, so on and so forth. So then the question is, okay, why not bring in a private partner who has understood how the entire value chain of how to be able to deliver services efficiently and at quality standards that are recognized, come in partner with government, build the capacity of a county government, again, build the capacity of a county government, not take over the government roles and responsibilities, build the capacity of the county government in terms of staffing, really helping them think through what does inventory management look like, what does service delivery and quality accreditation look like, and be paid for it as a result. And that means by improving efficiencies, you're able to tackle all those numbers that you are missing, you're able to capture them, right? So there are other models where we've been able to see whether it's thinking, and especially in this situation where you're looking at the ultrasound, is an equipment placement justified? Is that something that makes sense in this situation? And what would be the financial mechanisms look like? We're also looking at issues around, for example, when you're looking at the service, the SLAs, how have they been catered to ensure that equipment, it was servicing and maintenance, which in most cases, I can assure you when you go to most government facilities, servicing and maintenance is almost a second thought. It's only after it's broken down and you're starting to look for people is when servicing that you realize how much it actually costs. So it's really supporting the county governments to have those documents in place, doing the math, doing the capabilities to understand, okay, this is what it will cost me to be able to bring in a private partner. These are the legal and regulatory mechanisms that I can be able to use to bring in a private partner, and these are the outcomes I want to see for my patient in the end. And back to, in terms of what the key enablers have really been, and I'm winding up, is in terms of FIF. And Robert here, I'm sure, will explain it in more detail because he's the expert here. So one of the key enablers has been, even when we've been setting up, supporting county governments to set up these PPCs, the key challenge is, when will I be paid? How will I be paid? How often will I be paid? Am I even sure that I'm going to be paid? And that's when the issues of facility autonomy really come in. So it's how are we ring-fencing the user fees that we're collecting if we're for example, in a level 4. But again, like Dr. said, there's nothing which is free of charge. Even when you're delivering it in a PHC, somebody has to pay for it. So are we ring-fencing that money? And then how are we reconciling it? Because again, it's a pool of money from radiology, from the lab, from consultation, etc., to make sure that the private partner is paid on time. The second thing is in terms of waivers and exemptions. And like one thing that was mentioned is that waivers are important, and we understand the value of waivers. And one of the biggest learning that we came to see when we were engaging different counties is a lot of county governments don't understand how much money they're, in quotes, losing because of waivers. Because a waiver is a fee. It's not free of charge. A patient, yes, will not pay, but the government has to pay for it. So thinking around those different financial issues that might come up when it comes now in terms of paying this private partner. And I would say, finally, one of the other key things is NHIF. So when we were looking around our work at Linda Mama as well at Chai, we found out it costs, for 4 visits for a mother, it costs about $1,350, I would say. And Julie can correct me if I'm wrong. 1,350. Is it 600 for the first ANC, 250 for the other 3, if I'm not wrong, around that. So let's say 1,500. But if you actually cost what it will cost for that one mother, for those 4 ANC visits, about 3,500. So even if a facility is claiming for NHIF and they get their 1,500 back, the actual cost to deliver the service is 3,500. And that's not including utilities, labor, and so on. So you find that even as we're thinking about PPCs, it's really thinking about where that money is coming from and making sure that we optimize how we collect it to pay back the private partner. Yeah.
Good. Thanks, Maggie. I know your wisdom might, we have to cut it short because we will soon be having constipation of your wisdom. And I'm sure there'll be people with questions for you. So I know, so you throw the ball, and I think you've thrown the ball with heavy questions to Robert. So Robert, the bigger conversation here has been we want to drive as much as possible POCUS to PHC. But we know PHC, no fees, no user fees at PHC. I think there's been a lot of conversations around when 2018, when UHC was announced, one of the key declarations was the government will be sending something we call user fees forgone, right? So counties were asked to stop charging user fees and the government to reimburse them on something we call user fees forgone. This was about 2018. And so in that background and a lot of other backgrounds, it will be interesting to see what mechanisms do you think the counties can have in terms of just either purchasing or reimbursements for these services and a couple of others, just to get the services accessible at public at that level. And the other conversation which is important for you to consider in this, a recent Lancet Commission study on PHC financing demonstrated that a larger chunk of PHC services out of pocket is actually on either diagnostics or medicines. Why? Not at the facility, because in most cases, those two are not available at the facility, so the patient has to walk out and go purchase that from outside. So with that sort of a background, where do you see the role of the county governments? How can we partner with the county governments to roll out, POCUS? But most importantly, what sort of reimbursement mechanisms can be set to enable that happen? Over to you, Robert.
Okay, so I don't know where to start, but I'll say we are at a crossroad as counties, because from NHF, she says if you are to pay 3,000 shillings for every mother, for the 1.5 million mothers in the country, at a minimum of 3,000, we are talking of 4.5 billion. If we go the capitation way, we are saying that counties will offer the same service at less than $500 million, meaning that if the counties were to offer that service that NHF is not reimbursing, the counties will lose almost 4 billion yearly, which you don't know where the money is coming from. The bigger picture is all the 47 counties have around 100 billion, 110 billion in terms of all their health budget. And yet they are managing 99.9% of public health facilities. So even as we talk about this, we need to really have a discussion as a country, where exactly is the money? Because if you're having 110 billion and you are managing 99% of the public health facilities, are you able to do that? So it's a tricky question. On the user fees for gone is something that used to work very well for the facilities when it was removed and then the money put as part of the pool. Then we got it wrong, because now when it comes as part of the exchequer resource to the county, it can go to roads, it can go to agriculture, to any other sector. So I think the better way was to ring-fence the money so that it's coming towards health, and then we use it within health. So I'm looking at this POC, and the bigger picture, it will address the third delay. We have had a lot of complaints around, the 3 delays. But with this one, I think the third delay, this will address. And I'm looking at this in terms of the opportunities to partner with the OMs here. That one, through on-source budget, although we have small money, but through that money, we can be able still to procure if we talk well to the politicians, because we have to make our case where we need to procure this. So with the on-source budgets, we can get some small money to procure. Then I think what mentioned are around health facility autonomy. I think I look at this as the game changer. It's very hard, for example, for Philips to go and enter into an agreement with the County X, because the dynamics of getting into an MOU with the county government and then starting following your payments, delays and all that. But it's very easy for a company X to go to a facility and then do a contract with that facility, and then the facility pays. I think it's easier to hold a facility in charge who is the accounting officer in that facility to account than holding the governor and the chief officer of finance and the other people there. So I look at the discussions around health facility autonomy, whether our facilities are able to be declared entities, they're able to procure, they're able to make decisions around all these issues. And we are talking of facilities from level 2. There are facilities that are raising around 2 million, level 2 facilities. If you're able to raise 2 million and this equipment costs like 300,000, it means if you enter into an agreement with that facility, every quarter that facility can easily pay you 150,000. Bigger facilities, level 4 and level 5, which are raising over $500 million, they're able to procure this very easily if you have an arrangement with them. So in terms of public-private collaboration, I think it's an interesting place. The other way I look at it for the counties to tap in is the development impact bonds. It gives us a results-based, kind of contracting. We can get more money from that. Then the other way is the banks. I don't know if we have any financial institutions in place. I think it has worked very well in the private sector, where you'll find, for example, Aga Khan and KCB enter into an agreement and then they finance. I don't know why that cannot happen with government, but I think it's a possibility that can happen. The other way is for the national government to just be deliberate and then procure and then send to the counties, the way we have done with the CHP kits. We can set a budget as a country, then we procure, in large quantities and then send all that to the counties. So then finally, it's just to say that the counties as currently constituted, they are very strained. If you look at the health budget, over 70% going to pay salaries. Whatever remains is so small even to buy commodities. But we are seeing that even with that little amount, we can be able to do a lot.
Good, thank you, Robert. So I'll wish to maybe now open the session to the floor. I know we have a couple of questions. This is where all pieces have to tie, that we've talked about all the regulatory and other aspects, but it won't mean anything if we don't really agree around how do we purchase or how do we pay, how do we make sure that the patients actually have access to it. So questions, please. Yeah, so I can see 2 hands up. Steve.
Yeah, thank you. So my question is to Robert. My first question is to Robert. You talked about ring fencing, and I really liked the model of sorry, not Robert, but I think it was Meg who talked about ring fencing. So the question is to the experiences by the COG on the ground, because we all know that that's a very sustainable model, whereby as a public institution, you know this is the amount of revenue you're generating, and if you circulate it within the same healthcare facilities, then that can allow sustainable healthcare provision models like POCUS to actually flourish and, to make sense. So my question is, how has been your experience towards that? I know Kajiado, the county where I live, tried that. What's the success story like? Because that could easily affect the viability of such projects. I think the other comment would be on as regards to, even as we look at the cost of financing for healthcare and POCUS specifically, the per capita expenditure I think is about $83. And NHIF have said that their reimbursement from the last assessment, they put it at 3,000. How does that play out in terms of long-term rollout of these programs, now that you have cheaper solutions, which arguably, let's say, 20% of the cost of the original, let's say the older ultrasound machines. So you have a cheaper cost of the equipment. What about the other critical aspect, which is the training, the support, the back-end support, and the human resource, and also quality improvement as well? What's your comment on the costings on that? And maybe, Meg, you could add on to that, so that it's done in a sustainable way for the long-term solution. Because I like what Dr. Maggie said in the morning. Things don't go wrong, they start wrong. We hopefully have an opportunity to start right this time.
Thanks, Steve. Next.
Thank you. My name is Anthony Mamati, and I'm the marketing manager for Mindray Central Africa. Maybe I would have been more useful on the previous panel, but also since I'm an economics scholar, I'd just like to share a question to the panel, which they can look into. So one of the things that was mentioned is that there was a lot of claims from the insurance perspective, and that led to the shift on the model, which they looked at reimbursement. So maybe my question would be, first, did you check what were the drivers for the reimbursement? Or did you just see the claims come in and you felt, then let's shift the goalpost? Because again, the players can still target the new goalpost. So did you check out the drivers? Because one of the drivers is usually the issue of other reasons behind the incentive that motivates people to do that claim. So maybe I just wanted to find out, did you check the drivers for that kind of claim so that you can know how to do it? And then the second one is, much as we are talking about the issue of cost, and we are positioning cost so much as one of the key drivers on uptake, but what I've also come to find out is that uptake of these services sometimes is influenced beyond the cost. Radiological examination and ultrasound being part of it, there's this issue of the fear of what happens or the safety of that. So the uptake, you mentioned about 25%, but what others of those who are given the request form to seek services and they don't seek it because they fear going to hospital? So we might be having a larger population who do not seek the services because of fear. So is this program also looking into educating the masses about the value of ultrasound per se, so that more and more can seek it, rather than looking at those who seek and they are able to pay? So the element of health literacy also, how are we looking into it? Thank you.
Good. Any other? I know when Julia hears that people need to be educated, the greatest fear that she has is supply induced demand. And I'm sure she's going to talk about that. So let me have the third question from Mika.
Thanks for the presentations. My concern is I feel like we are costing a service that is so affordable. We're putting a price that is so high. Where we're calculating a rate of 3,000 shillings per woman to do a point-of-care ultrasound screening. Why so? Because I feel it's almost 4 times what we have proven outside there. $5 is enough to do a point-of-care ultrasound screening. We have proven it. That money is enough to purchase supplies and incentivize a caregiver. So are we after profit making, or we are after making a service accessible? That's my question. And if we are not able to cater for that within the current package, I always ask myself, is there any problem having, we have the package of free services in primary healthcare. Those are absolutely free, in quotes, that they have been funded for. Can we introduce a brand B, where there is room for value-adding services, there is a level of a co-payment? Because I imagine a situation, a mother pays $2, and then a child foots the rest of the $3. Will that make the service sustainably available within the community? I'm just asking myself on funding models or financing models. But what I'm not finding convincing is asking for $30 to do a point-of-care ultrasound screening. Already in one of the counties where we are working in, the county has fixed a price of $10 for ultrasound screening. And that is using the old technology, the physics model that is already mounted somewhere, where people have to go to a facility and have them screened. But it's costing only $10, which we still find is very high because mothers are not going for it. They keep asking for, why is that ultrasound for $5? It's the one I want, not the one for $10. Because they have been convinced that the service can be available at an affordable price. So why the $30? I'm not understanding.
Good. So you will clarify that. I think there was a question. Charlotte, did you have a question? Okay. So, yeah. Who had a question? Oh, okay. Yeah, I remember I saw your hand up. So.
No, I just had a general question. I think we've heard a lot about ring fencing as a solution, but I was wondering if you've seen any other innovative financing mechanisms that have enabled uptake of other healthcare or any healthcare solutions or services in Kenya, either from the private or public sector. So I think we mentioned development impact bonds. We've also seen working capital funds for healthcare facilities, or maybe things like de-risking funds for OEMs. It would be great to hear if you have any specific examples on these and whether they've been successful. Thanks.
Good. I know the questions cut across all of you, so I'll probably begin from extreme right. The 3,000, maybe it can be clarified.
I have someone here. Clarify, please.
The price that was mentioned is a price in the market now, before we disrupt it with point-of-care ultrasound. If you go to most medical facilities, if you come to Metropolitan, if you go to Aga Khan, ultrasound is between 2,500 all the way up to 6,000. So if you use that model, NHIF goes broke, and the women can't afford it. So the alternative is the point of care. And the question is, what does it cost in a public facility, and what does it cost to do economically for someone who is paying for the device, paying for the maintenance on a full cost basis? Because that's what we need in the private sector, whereas the counties have a portion that is tax funded. We have no funding. We even pay banks interest.
Thank you,
Okay,
Dr.
Julia.
Yeah, I have someone watching my back. Thank you. May you live long. Now, having said that, it's not that NHIF is not paying for ultrasound. NHIF pays for ultrasound. We have packaged it in capitation. But a healthcare provider will say, no, that is too little. So we need to work around that cost. NHIF also manages medical covers for groups, for the government employees, for county governments, for a lot of other institutions. So we call them the managed schemes. So we manage schemes, medical schemes from many. In these medical schemes, what we are seeing playing in our database is ultrasounds of between 3 to 5,500 thereabout. So that is what we get, because in the managed schemes, we pay at cost. We pay as invoiced. And here is a member who's aware of their allocations. So they are keen to see that they do not overutilize, because it's a family cover. But in the national scheme where we rolled out 3,000, the member had no limits. They have no limits. So NHIF will pay. So the hospital was just billing. And it was not ultrasound for maternity only. It was a flat rate for any ultrasound. And we would see simple things like abdominal pain is the complaint, presenting complaint. Management, number 1, abdominal ultrasound, even if it is you. At times you would see something very simple. Number 1, ultrasound. Why? Because someone is taking care of the costs. Deliveries, all of them had an ultrasound cost to them. We could not proceed. And that is why we advised the board, and it was taken into the capitation funds. So in comes point of care. How much are you willing to take? How much are we willing to negotiate with healthcare providers that we are going to pay? Are we going to pay it as a package where our feet developed cold? Or is it going to be part in the antenatal fees so that there's a slight increase in it and their care is taken care of? How are we going to have the arrangements with the healthcare provider as an insurer? So it is not that it is not taken care of, it is, but there are issues around the financing. The main driver which we saw there, which we can say was supplier induced. There were numerous requests for ultrasounds from healthcare providers. Whether they are done or not is another thing. So it was basically on that end of the financing.
Good. Thanks, Julia. So just a yes or no. If we packaged this as NC profile and have it as in this list of NC profile of HB, VDRL, hepatitis, then we add ultrasound, will that be a good idea?
If who packaged? You.
All of us in the room, including the department, especially the Division of Reproductive Health, and saying, as one of the interventions, we are going to adopt, I think one of the things that has been voiced all over in the morning around the new not the new guidelines, but the existing guidelines around having at least one ultrasound.
So then in that case, we will not be looking at the free maternity only, we'll be looking at the entire maternity, even the ones we finance as NHIF, because the free maternity one is funded, the amount is fixed, so we would have to go back to government and tell them there is this addition that has come in and it's going to cost this much. Are you willing to add more money? Of course, the answer is rather obvious, but if healthcare providers are willing to work with what we can negotiate, we think is sustainable within what government gives. Because if you want government to turn your books aside, just ask for money. They will put it like this. But if we can do it within, then that will be an agreement between healthcare providers, the insurer, working within what the government has given us. And as NHIF, we not only take care of free maternity, we also have members whose maternity we pay for. So then it will also spill over to them, and then it's now a countrywide benefit to any mother who is expectant.
Good. Thank you. Dr. Gakombe, a quick 1 minute take.
Yes. The first is, for me, a lot of our problems will lie in using technology. It is possible not only to ring-fence money, but to ring-fence services. If you should do 4 ultrasounds or 3 ultrasounds during a pregnancy, it's not very difficult to configure the NHIF system and the claim systems you use to tell you you've already maxed what you're supposed to do. If you're a dentist and you pull out one tooth, then the system should not allow you to pull that tooth again. You can do other things, but not an extraction because you already extracted. And those solutions are available because some of the ones I'm saying are available at Metropolitan. Our dental system will not allow you to do the same thing on a tooth if it should only be done once. So it's possible with all the capacity in this country, local and imported, to make sure that we have guardrails to guard the money from those who want to abuse it. And NHIF, and this is a challenge to my sister here, we need to look at best practice and come to places like this and sell it. NHIF says people steal their money. I would want them to come and say, we are giving awards to those like Metropolitan who don't steal. Then the rest can see, okay, it is possible to be ranked higher by insurance and have an easier time if we are playing by the rules. Because right now, there is no benefit in being a good guy within this space. So the industry needs to give incentives for doctors, for nurses, for providers, for everybody in the industry, for manufacturers to be the good guys. Because in the absence of that, the person who is charging for ultrasound and not doing it is the one earning the greatest profit. Because they incurred no cost. They didn't do the test, so there was no cost of a reagent, but they have charged NHI for it. So the incentive structure in the entire industry needs to be reconfigured so that we point people in the right direction for care. There was a question about innovative financing. One of the most useful tools available to us today is placements. And it's important that we separate the providers from the counties. Because unfortunately, Kenya is 60 years now, but for the health sector, Uhuru never came. Not Kenyatta, independence never came. Government schools, and I keep asking this question wherever I have an opportunity. I was a student in a high school. The school could procure teachers, procure firewood, procure bread, build, raise money, go to the Clinton Foundation and do stuff. I keep asking, why can't a level 5 hospital have the same latitude that Alliance High School has? Why do we think that teachers can run a budget and doctors and healthcare workers cannot? Yeah? So as we do these health sector reforms that you're doing, it is very, very important that one of the most critical reforms we ask for is how to ring-fence healthcare facilities so that the money they get, they are able to run independently. And at the risk of taking 30 seconds longer, NHIF used to be a department under the Ministry of Health, and it was a very useless organization. We now have a much, much better organization today with a board and a management and accountability to providers and to parliament and to others. And so was KRA. It was a department in the ministry, in treasury. And most of the tax they collected were for themselves. So my experience is that every time you create an organization and ring fence it, it tends to perform better. So we have a chance as the laws are passing to make sure that one for the county passes, because they'll never be able to do what she's saying they should do. But on innovative financing, there is invoice discounting. There are people like the Medical Credit Fund who not only give money, but they also demand a certain level of quality that you provide. We've done leasing. Placement has been very useful. We have supplier credit. Many of the suppliers in this room are fairly generous in allowing us to pay on some, installments, right? But there is a lot of room for improvement. And to me, the best model is pay as you use. Equipment as a service, not as a tool. So that we have a shared responsibility with Philips and GE that as I use the equipment, we are sharing the benefit. We are sharing the benefit and the risk. It will remove a major barrier that we have because the equipment is expensive and it becomes obsolete. And then we don't know what to do with it. Yes.
Good. Thanks, Dr. Kombe. Maggie, your turn, maybe a quick 1 minute take.
Definitely. So I'll not belabor the point, but even for the innovative financing mechanisms, actually let me just belabor. Ring fencing is very important because a government the county health teams have to be able to have access and control of that money to be able to allow them to even participate in those innovative financing mechanisms. I think the second question was around the costing. So there was a question there around, even when we're thinking about costing, it's not just the actual doing of the scans. It's beyond that, the training, considering all these other different elements that are necessary to allow that POCs, POCUS, is actually implemented and rolled out at a primary healthcare level. And I agree, that's something that definitely needs to be taken into account. And maybe that's where the blended financing aspects come in. It might be an NGO that supports that aspect, but the government is the one who controls how the payment processes and so on. So yes, I completely agree. Then the third was around demand generation. And yes, even with PPCs, I think one of the key things that is very important is how we create and generate demand. I know in the morning there was challenges around medicalization, potentially because you have access. I don't think that's the case. I think it's really a matter of how to be able to be clear in terms of what the use cases are. And in this case, I think we're clear, it's screening. Every mother that comes through will be able to get an ultrasound done the same way they're done for a HB, a glucose, a urinalysis. That is the standard package of care that a mother should be able to get. Finally, I think I'll just wind up by saying there is appetite for PPCs. The counties have appetite for it. They need more guidance in terms of the hows of doing it. The models are many, and Dr. He has mentioned from placement to leasing to contracting out, outsourcing, they're there. And there are legal mechanisms to be able to support it. I think it's us to be able to now start creating that enabling environment to allow that we work together to start seeing PPCs beyond just infrastructure, but within the service sector as well.
Good. Robert, 1 minute, and then you wrap this up.
Okay, very fast, I just answered the question around experience from counties. So far, around 31 counties have already enacted laws to ring fence money, or rather to retain money. Unfortunately, almost 90% have gone for the fund, where they're creating a fund with a fund manager and a fund structure, and we advise them against that. That's why we are doing now a national, and even the COG model that you're advising, that you don't create a fund, because you create a fund and you introduce a new structure within the health setup. So we're just saying that retain money, collect, retain, and then spend through appropriation in aid. There are so many experiences, Bungoma County, Nakuru, Mombasa, Makueni, so many counties raising up to 1.8 billion in a year in health. And then recently, I think in November, there was a study by CRA and World Bank. And from the study, they say that if the counties are able to do some reforms, they cited like two sectors that can really bring more revenues. There's lands and then health. In health, they can raise up to 3.7% of what they're raising now. So if Nakuru is able to raise 1.8 billion, if you multiply like even twice that, then it means Nakuru can be able to fund itself minus relying on the exchequer. So the potential is there, and a good example is Homa Bay County. Recently, they enacted the law. I think Homa Bay, from the last regime, the entire county was collecting around 300 million a year. Now, after enacting the FIF law just 2-3 months ago, in the last 2 months, they're averaging 99 million in a month. So if they go with that trend of 99 million, it means they can raise 1 billion shillings in a year. With 1 billion shillings, it means they have more resources to do other things that they would have not done before that. So I think FIF can work. It's just a matter of us in supporting the counties. Then once they have the money, we ensure that the money goes to the right thing. We also don't want to, we are not into the business of raising money in health. We are not into revenue generation. Unfortunately, in this country, health is the biggest revenue earner for all the 47 counties, which is an unfortunate thing. We are telling that people should look for money from other sources and not health, because if we treat it as a revenue earner, then we are likely to marginalize our people where access will be limited.
Good. So thanks again. I'd like to thank the panelists. Please, let's give them a round of applause. So as they take their seats, I think one thing is clear. As we talk about the money, the most important thing to imagine that this should translate into a mother walking home with a baby alive. So if it does not end like that, the rest becomes an academic exercise. Thank you.
Dr. Dr. Serem asked us to try and close this by 4. I think we are going to be a few minutes longer, but I just wanted to try and summarize some of the emerging themes from our discussion today. But before I do that, I think I just want to thank everyone who stuck with us for the whole day. This is a beautiful city. There's UHC. I think something was being launched down the road about community health workers. There are lots of nice things happening, but you stuck with us. So thank you so much for being with us today and for providing very useful inputs. This is the beginning of a conversation, and we want to continue talking, because when we stop talking, we start fighting. There's a lot to be done, and we have some agreements. I can see the areas of agreement that are emerging as follows. The need for point-of-care ultrasound, I think today was not disputed by any participant. We all agree that it is necessary, so we don't want to revisit that debate. We also seem to be agreeing that what we are talking about today is primarily to focus on the PHC. Across several presentations today, it was very clear that we need to standardize the training, because different players are conducting different trainings for for different durations and using different methodologies. But there are a few areas that will require more work, and we encourage you to remain engaged as we'll follow up with individual participants today to ask you to continue engaging with the teams in different areas. There's a whole area of policy, legal, and regulatory reforms that would make POCUS functional in Kenya. So this is an area that requires a lot of work, and through the Ministry of Health, we have we will identify key champions from this group and others that are not here with us today to continue working in that space, so that we have an investment climate or a regulatory framework that can allow all participants to be able to do training, to deploy the different technologies, and to provide the service while addressing all the risks that have been clearly identified today. The second big area, and I think it's something that we'll need to work further on, is on training. Training in a sense that this is a very broad and complex subject. Are we talking about the comprehensive training that obstetricians and sonographers have always done as a part of quality obstetric care, or something else? That delineation needs to happen. Who will do the training? How will the training be done? Who can enter into this training program, and for how long should they be trained? I don't think we had enough time today to dig deeper into this subject area and to come up with at least a solution. I think at the end of the day, we will have something that addresses the different needs for different cadres. There could be the shorter term training that can be graduated to other more complex trainings, depending on what individual professionals want to use this technology for. For example, the training that you need for the rapid screening of complications in obstetrics will be very different from someone who wants to use this for cardiac or something like that. But there's a need to be a continuum of training that people can take. I think the other part that we'll need to talk about is the more operational deployment, assuming that at some point we've addressed these issues of training, policy, legal and regulatory affairs, and now we want to deploy this at scale for service delivery. How does that look like? And I think this is where we'll need to engage the counties, we'll need to engage hospital associations, we'll need to engage CHAC and others to figure out the best way or the different pathways that we can exploit to ensure that this service is available to all. Today, most of the conversation was around using the government system. But I'm here to tell you that in terms of health service utilization, you can't go far if you only use the public healthcare system. So under this, we will need to engage all the key service delivery providers, particularly in the rural areas, to ensure that as we are making progress with the public sector, we do not forget the non-state providers of healthcare services, who, from a historical perspective, have actually been providing services long before the government started providing services. The last part will be on the financing. I've enjoyed this very difficult discussion on different payment mechanisms, and I think we didn't fully address it. How do we structure ways through which we can deploy this at scale without necessarily, while still committing ourselves to the UHC principles, which I think try to make sure that women do not pay for services at the point of need. So we want them to access these services without financial barriers. So how do we, for example, tweak the AMREF model for it to work as well as it is working without necessarily placing the burden on the woman who needs the service at that point in time? So these are issues that we'll need to continue working on. And we must continue engaging our technology providers. I think we had a sample of them in the room today. These technologies, especially with the AI component, are very rapidly evolving. Your AI solution will be just as good as the feedback that you provide from your market. If we don't have a mechanism to give Butterfly and everybody who's working in this space feedback on the Kenyan data, they need feedback on the Kenyan patient. We need a lot of input on the Kenyan mother and the pregnant woman from this market or this population to make AI function for us. If we use data from Vietnam, it may not be as accurate as it should be for the Kenyan woman. So I think, and I don't have a mechanism to do that, but my appeal through the government is that we must find a way of continuing to provide big data or feeding into the big data with as many data units from Kenya as possible, the region as possible, so that whatever algorithms come up with eventually will make sense for our populations, which are unique in some ways. With that, I will invite Dr. Serem from the Ministry of Health to really give us the matching orders on where do we go next with this important agenda. Thank you very much, everyone, for participating today. Thank you.
Thank you very much, Dr. Olayo. Yes, we have had a long day here. Yes, and I want to thank all of you for your contributions. And first of all, I must say I'm delighted that this activity has happened today. It has been on my desk for quite some time. And I really had to get some time to dispense this exercise. We have had a robust discussion on the issues of POCUS. And as has been summarized by Dr. Olayo, I think the issues are very clear. While we engage on this discussion, it suffices to mention that we have had representations from diverse groups of interest and stakeholders on this, and not to mention the partners, our colleagues from the training institutions, the regulatory bodies, research institutions, and the manufacturers, or rather the technology innovators. And it's true that throughout our discussion, as you could have noticed, that I never stepped out, because I had to make sure that I grasp everything. What are your thoughts on this? Because it is something which is new. And of course, when something is new, you have to get the concept right. So as we have said, it's true. And while I was seated here, I actually learned that a lot of works have been going on, which is good. And this is a global innovation, some form of creativity. And the important thing about it is, it in a way will address some of the issues which we are grappling up with. This is to do with perinatal, neonatal, maternal mortality. So one thing which is there very clear, therefore, is, as I had mentioned, that this was like an inaugural discussion, brainstorming, and I think we are in agreement that we are going to set the ball rolling in the process of development of the policy guidelines on this matter. The other critical issue, which has also been mentioned by my colleague Olayo, is on, of course, as we do that, we will also critically be thinking and also conversing on the issues of the training curriculum. As has been said, yes, what will happen? We need to be thinking ahead. What will happen for the training institutions? Standardization. What will happen for those ones who are in service? Supposing we say yes, we want to adopt point of care ultrasound. What will happen to the issues of certification on raising on matters of quality? So on this, I think those are one of the heavy discussions which will go on. And of course, modes of regulation, which will go hand in hand with the training curriculum, and of course, the use of the gadgets. So as we do this, of course, other things which also came out clearly is we have different modes of POCUS. For me, I'll speak for reproductive maternal health. There were issues of the pulmonary aspects, cardiovascular, point of care ultrasound. All these, I don't know if you will dissect or if you will have a general kind of guide to guide all of them. So I think those are also the discussions which are going to be ahead. So moving forward, therefore, is the first priority is, of course, coming up with the guidelines. And I think that is now the conversation which we have initiated here today. So we are going to work hand in hand, closely and rapidly, to see that we fast-track the development of the guidelines, policy guidelines. Two, to make sure that as part of our process in all the developments of any guidelines in the Kenyan government, of course there is a process. So we will make sure that the process is followed and adhered to, because we have different players here. There was a colleague here from the radiologist and the imaging department. They have to be heavily involved on these, and the regulatory bodies. So that process will take its due process. And I want to assure you that everybody will be involved. And at the end of it all, I hope that we are going to have a document which will speak to Kenyans and which will make our work very easy. So with those, therefore, of course, there are reforms which are happening. And when you talk about the issue of funding, well, to me, I don't see it as a big barrier, because I remember the first time when we had cell phones, and I was told it used to cost about 200,000 those days. And of course, with the technological innovations, things are changing very fast. And don't be surprised that by the time we are having more recent gadgets of these, they will be much cheaper. So, I mean, that is something which we will discuss at the point of when we reach there. So, I want to thank all of you for your participation. You are still going to be engaged as we move further, because by the time we are accomplishing the guidelines, all these questions which you have raised will have been addressed in the guidelines. So with those very many remarks, thank you again. I therefore declare this one-day brainstorming exchange of ideas on issues of point-of-care ultrasound officially closed. Thank you.
Tea will be served, and there's a lot of traffic out here, so don't be in a hurry to leave. Interact with each other and continue the conversation. Thank you.